Good morning, everyone, and welcome to today's wonderful beginning of rapid marathon session. So, the last 20 days is such a time where in 4 to 5 hours, if we are able to revise, then we are accomplishing something. Now, menstrual cycle. So, you know, what is the range of cycle? 21 to 35 days. Day 1 to 5 is a menstrual period, and 2/3 of the endometrium is shed during that phase. Now, what is the endometrial thickness after the menses are over? It is around 1 millimeters. 6th to 13th day is called proliferative phase. And what is the thickness during the proliferative phase? It is between 5 to 8 millimeters is what you need to remember. Estrogen is the predominant hormone during the proliferative phase, and FSH is the predominant gonadotropin during the proliferative phase. Which day is called ovulation day? Day 14, triggered by the LH surge. Now, what are the 4 P's of ovulation you need to remember? Proteolytic enzymes, progesterone, which is induced by the rise of FSH. And there are plasminogen activators which lead to the breakdown. What is plasmin? Plasmin is called antithrombin. So this antithrombin is required in order to let the ovum get released, and prostaglandins. Then what is the key feature if you do biopsy of endometrium? Once ovulation happened, secretory phase will begin. So what is the proof on endometrial biopsy that there is an ovulation? It is the basal vacuolation, vacuoles form in the endometrium, which is the confirmation. Is it a normal temperature? No?
Yeah.
Now, whenever it is secretory phase, what is the endometrial thickness? That is after ovulation. It is 12 to 14 millimeters. So all these obstetricians, they'll be very busy in evaluating whether ovulation happened or not based upon the transvaginal ultrasound, through which we can be able to measure the endometrial thickness, right? Now, once a woman crosses menopause, what is expected endometrial thickness? Less than 3 mm. And any thickness more than 4 mm, you need to do the endometrial biopsy because it is suspicious of endometrial malignancy, right?
Yeah.
Then what happens to the various glands in the endometrium once ovulation occurs? They all become tortuous, they become saccular. So you need to review on the Google the pre-ovulatory, post-ovulatory, endometrial histology. Make a point.
Yeah.
So that you need to review. Come on, quickly, one MCQ. 29-year-old with cyclical lower abdominal pain, her cycles are regular every 28 days. And on biopsy, which is being taken on the day 22, there is a basal vacuolation. So vacuolation is there means ovulation has happened is what you need to remember. Similarly, a 35-year-old woman has abnormal uterine bleeding and transvaginal ultrasound is showing endometrial thickness of 5 millimeters and she is postmenopausal. What do you want to do? We have to do the endometrial biopsy if the thickness is more than 3 millimeters is what you should remember. A 24-year-old with regular 28 menstrual day wants to conceive, and what is the most fertile period to have the intercourse for the conception to occur? Day 14, because that is the day of ovulation. Clear? Now, let's take up some hormones, favorite questions of the examiner. So, there are totally 145 pages. Okay. But these 145 pages can be revised in 4 hours. That's all is obstetrics. So, this is what you call a full and final notes. Okay. We have tried many notes. Yeah. Right now, FSH. Typically, FSH is responsible for making the follicles to grow towards the ovulation. LH will trigger, and estrogen will peak before the ovulation. Progesterone is produced after the ovulation by the corpus luteum, and it will cause the endometrium to enter from a proliferative phase into a secretory phase is what you need to remember. Right? Now, what will happen to corpus luteum? Typically by the 25th day, if at 21st day, if at all fertilization didn't happen, then it will degenerate. That will decrease the progesterone, and a decreased progesterone is a stimulus for the menstruation to happen is what you need to remember. Then what is meant by Mittelschmerz? Mid-cycle ovulatory pain because of the rupture of the follicle is called the Mittelschmerz.
So you love with milk.
Milk add cheyandi. Thank you. And like filter coffee laga untadi. Good. So a lot of fringe benefits. A lot of fringe benefits for teaching. The best coffee. Now, who leads to the LH surge at the time of ovulation? Typically, the follicle is growing under the influence of FSH. That growing follicle is the one which is producing estrogen, and estrogen keep increasing as you are approaching towards the day of the ovulation, and it reaches the peak, and that goes to the pituitary and causes the release of the LH is what we need to remember. Good into the sequence. Now, whenever you are doing in vitro fertilization, you won't give LH. In place of LH, you will give HCG, because the alpha subunit of the HCG, it has alpha and beta subunit. Beta HCG is what you monitor for pregnancy. Alpha subunit of it is analogous to LH. So instead of giving LH, HCG is used in order to induce the ovulation during the IVF is what we need to remember. Now, what are granulosa cells and theca cells? Granulosa cells convert the androgens into estrogen, and it is the FSH which will come, and it will make the growing follicles theca cells to convert androgens into estrogen and get the estrogen released. Clear? So that is the granulosa cells. Yeah. And the theca cells are the ones which produce under the influence of LH the androgen. Okay. That's the reason in PCOD, there is excess LH, excess androgen production, and that leads to hirsutism, etc., etc. Because you should remember, granulosa is girly because it produces estrogen, aromatase, FSH dependent. Theca is boyish, that is hirsutism. It will produce the androgens under the LH stimulation is what we need to remember. So finally, if there is no pregnancy, corpus luteum has no role and it typically will get degenerated, and that is called corpus albicans is what we need to remember. So now a couple of questions. A 26-year-old undergoing evaluation for infertility is scheduled for a HCG injection to induce ovulation. Which hormone surge is mimicked by this injection? LH surge is the one which is basically mimicked. A 28-year-old unilateral lower abdominal pain around 14th day of her cycle. She reports it resolves on its own. So what is your diagnosis, doctor? It is the Mittelschmerz, which is mid-cycle ovulatory pain is what we need to remember. A woman presents with amenorrhea. The hormonal analysis show a persistently elevated progesterone. What is the most likely possibility? It is pregnancy. Progesterone is maintained by corpus luteum in the pregnancy because of the HCG is what we need to remember. All right. Now, let us talk about the corpus luteum quickly. So, what is the role of the corpus luteum? To produce the progesterone and maintain the endometrium when the pregnancy occurs. Right? So, it produces four things: estradiol, progesterone, inhibin A, relaxin. These are the four things which are being produced. For how long corpus luteum will remain alive? Up to 12 to 14 days in a non-pregnant cycle, and typically its action is peak by 8th day post-ovulation. That's the reason implantation after fertilization also will occur by 8th day post-ovulation. So it will degenerate on 24th day. Now what is relaxin? Relaxin softens the uterus, softens the cervix, and prepares the uterus from not ejecting the conceptus, because relaxin is produced by the corpus luteum. What is inhibin A? Inhibin A inhibits the FSH and it is secreted by the corpus luteum is what we need to remember. Now, what is the main problem in PCOD? Whenever there is any prolactin disorder, PCOD, thyroid, in all this there is a, thank you. Sugar lega. In all this, there is a luteal phase defect is what we need to remember. All right. Now, let's quickly go to a few questions. A 32-year-old undergoing IVF in early pregnancy loss has early pregnancy loss. She has a low mid-luteal progesterone. What is the diagnosis? Eప్పుడైనా pregnancy maintain కావాలంటే post-ovulatory phase progesterone should be adequate. If that is not adequate, when there is a low progesterone in the luteal phase, luteal means post-ovulatory, then that lead to implantation failure. That can lead to. Which hormone prevents luteolysis and maintain the corpus luteum? It is the beta HCG that maintains the corpus luteum till placenta takes over. Who produces beta HCG if the pregnancy occurs? If the pregnancy occurs, syncytial trophoblast, they produce HCG. A 27-year-old woman with regular menses has a peak corpus luteum activity on day 22. When is the ovulation likely to have occurred? Day 14. Always remember, 8 days post-ovulation is the time where the corpus luteal activity will reaching the peak is what we need to remember. Now, the next favorite revision table is progesterone and granulosa theca cells. Already we finished most of the aspects of this. You can have a quick review, doctor. Now, yes. Progesterone is secretory phase, estrogen is proliferative phase is what we need to basically remember. Now, what is the effect of the progesterone and estrogen on the endometrial, on the secretions, cervical? Progesterone will lead to tacking. Estrogen will cause furning and spinner becket appearance. Okay, sorry, endometrial histology, where spin bucket, furning of estrogen under the estrogen influence and tacking on progesterone influence, how they look like. Commonly, they are asked as a image-based MCQ. Whenever estrogen is there, it will promote the growth of the endometrium, and that will create the copious watery mucosa. Mucus is what we need to understand. Now, 30-year-old woman trying to conceive tracks her basal body temperature and notes a sustained rise of temperature in the mid-cycle. Which hormone is responsible for this? Progesterone. Progesterone is thermogenic and it will get increased, responsible for the increased body temperature post-ovulation. So that is the reason one of the contraceptive method is called basal body temperature monitoring. If the woman monitors her basal body temperature, a rise of it indicates she is ovulating, and that is the time where she need to abstain from men's intercourse, so that she can prevent the pregnancy. A very rough way of contraception. In a study of cervical mucus pattern, one group showed tacky cellular mucus while other had thin, watery mucus with furning. Which hormone predominates the first group? Tacky unte? It is progesterone. That is thick, scanty mucus unte progesterone. Thin, watery mucus with furning unte estrogen. That's what we need to remember. A 32-year-old woman with recurrent early abortions is suspected to have luteal phase defect. Which urinary metabolite will confirm whether progesterone activity is good or not? Pregnanediol is the urinary marker of how good is the progesterone produced in the luteal phase. If it is defective, that lead to development of miscarriage. Now, let's talk about the next table, revision table, is progesterone effects and synthetic progestins. Okay, so totally there are 100 tables. From this 100 tables, 15 MCQs in obstetrics. कहीं भी नहीं जाएगा, इधर से ही आएगा, right? At least you will, इतना पढ़ने के बाद your guessing skills will improve like kissing skills, right? Now, progesterone, what is the effect of it on vaginal cells? Whenever progesterone is there, if you look at vaginal histology, it will stimulate the intermediate cell proliferation. How intermediate cells look like? Google will tell you. Then under the influence of estrogen, what will vaginal cells will show? They stimulate the superficial cells and high karyopyknotic index, right? Pyknosis means nucleus which is very dark is pyknotic cell. So typically when you look at vaginal cells, when estrogen is very high during the proliferative phase, that will stimulate the not intermediate cells but superficial cells, and karyopyknotic index will be very high, is what we need to remember, right? Then all the remaining points about the progesterone you need to read, doctor. Now, whenever a woman is having primary amenorrhea, right? So you have given estrogen, and after that you have given progesterone, and you have withdrawn the progesterone after a few days. What do you expect? Bleeding. Then what is your diagnosis? Oh, that means she is having amenorrhea because there is no ovulation. There is no progesterone. No problem with the uterus.
Yeah.
Right? No problem with the uterus. Problem is in the ovary. Problem will be there either in three places. What are the three? Himalayas, pituitary,
Yeah.
hypothalamus.
Yeah.
Then comes New Delhi, pituitary.
Yeah.
Or it can be there in the Hyderabad, which is ovary. Or it can be there in Janagam, which is uterus. So where is the problem? If you want to know, then we need to check with progesterone withdrawal. If progesterone withdrawal induces the bleeding after a few days of progesterone and withdrawal, that means typically she is having anovulation. But after progesterone withdrawal, if there is no bleeding, means it is a refractory endometrium. If there is no bleeding, that means the problem is there in not in the ovary and ovulation. It is there with the uterus itself. Coming to secondary amenorrhea. After progesterone withdrawal, if there is any bleeding, it indicates anovulation. Right? So now, what are the various synthetic progesterones we use? In order to give progesterone, look for the progesterone withdrawal, etc., we give first generation norethindrone, norethindrone acetate, ivanni. Then second generation of levonorgestrel, norgestrel, levonorgestrel, the one which we use for emergency contraception. Good to know?
Yeah.
Emergency contraception. Then what is the third generation? Disogestrel, gestodine, norgestimate. They are for better metabolic profile. Then fourth generation are drospirenone, right?
Yeah.
And numigestrol. They're all anti-androgenic, anti-mineralocorticoid effect will be there for them. What will mineralocorticoids will do? Mineralocorticoid, aldosterone and all. They retain the water and sodium. Whereas fourth generation progestins have got a anti-androgenic and anti-mineralocorticoid effect. Right? So that's the reason drospirenone and all are the preferred progestins is what we need to remember. Then what is the advantage of third generation progesterones? They have a better metabolic profile. Second generation progestins are levonorgestrel and norgestrel is what we need to remember. Now levonorgestrel, where do we use it, doctor? We use for emergency contraception levonorgestrel, menorrhagia, endometriosis, right? And whenever you are giving a hormone replacement therapy, only estrogen if you give, that will have many side effects. You need to combine with a progesterone. Then your favorite guy is levonorgestrel. Okay, that's the story. Now let's take quickly the questions. 25-year-old woman with secondary amenorrhea receives medroxyprogesterone for 5 days. She bleeds after the withdrawal. What does it indicate? Anovulation, right? A patient receives estrogen priming followed by progesterone but no withdrawal bleeding. Then where is the problem? The problem is in the endometrium, in the uterus, in the receptor level defect is the one which is responsible. Right? Whether it is high prolactin or PCOD or anovulation, all of them lead to anovulation. PCOD will go to anovulation. But if you give progesterone and withdraw, then there will be bleeding. That means the problem is not with the uterus, but the problem is with the ovary and ovulation and post-ovulatory progesterone production. Which of the following is a second generation synthetic progestin used in emergency contraception? Levonorgestrel. Right? Next, estrogen sources, types, mnemonics. Next table. Okay? This is, I think, table number 6 or so. It's a 100 gotali. Unda opika? And this is like what you call as I'm intrathecally pushing into your CSF the subject. Huh? Now you have no choice than to one day, one subject. See how constrained will be the time. But when time is enormously available, we ignore it. That's the whole problem with the time, right? And it looks very constricted in the last moment. But the most important thing is whether you studied across year or in this last 20 days, it is one and same. Many people, they miss the bus to consolidate in the last 20 days. They will lose the exam. That's the reason, let us consolidate precisely. No error, no flaw, no excess kind of a content we are revising now. Right? Now, what is the source of the estrogen? It is placenta, where syncytial trophoblasts produce estriol in the late pregnancy. Then estrogen can also come from adipose tissue, which will convert the androgens into estrone. So adipose tissue lo tayarayye estrogen entandi estrone, whereas placenta lo tayarayedi estriol. Corpus luteum produces estrogen. Theca cells, granulosa cells, they also do aromatization and then produce from the androgen. That is estradiol. Diol comes from luteum. Estrone comes from adipose tissue. And estriol comes from the placenta. And estrogen is also produced in the fetal liver. That's called estitrol, which is E4. Right? Just for fun, try to remember. Of all this, which is the most potent estrogen, doctor? Diol is most potent, seen in the reproductive years. Right? Di means husband plus wife. They are most powerful combination. So you can remember that way, estradiol. Then estriol, husband plus wife plus fetus. Pregnancy alone together. Yeah. If you want to know the fetal well-being, fetus manchugunada leda and teliyalante estriol levels you will assess. So you can remember triol is 3, husband, wife, fetus. That means in pregnancy, placenta. Yeah. Right? Then estrone, 1 is old and all alone wife. Husband already went to heaven. So you can remember estrone is postmenopausal women. Right? Then what is Ariostellas reaction? Whenever the progesterone is being produced, that will have an effect on the endometrial histology. Those histological changes of the influence of the progesterone are called Ariostellar reaction. Right? Now, what happens in pregnancy or the person who is taking OCPs? Estrogen levels will be high. In menopause, lactation, castration, GnRH analogs, if you are administering, that will cause a low estrogen is what we need to remember. Then what are the conditions where progesterone levels are high? Hydatidiform mole, RH isoimmunization and all this, it is high. Where is it low? Whenever there is an ectopic pregnancy or abortion, then the progesterone production will not be adequate. Right? So that's the reason it will be low. What lead to high and low of estrogen and progesterone? A 26-year-old woman in her second trimester, her urine sample is analyzed for the marker of the fetoplacental function. At a page 18 out of 287. Huh? Yeah, 297. Wow. Is any minutes in the 30? 30, huh? Oh. Very good. Nice, Mithuna, to see you online. Keep punching your answers that comes to your thought and mind. Are you comfortable? Yeah. Good. Could a washroom there? Yeah. Outside light in there. Oh. It is like a conference room. So 30 minutes, huh, in the
Yeah.
oh, the power అయిపోతుంది. కానీ ఎక్స్టెన్షన్ కష్టమైపోతుంది. ఇక్కడ ఇట్లా కనెక్ట్ చేద్దాం. ఇట్లా
Like extension box.
ఉందా?
Yeah.
Thank you. Yeah. So we can, I think, continue
Oh,
before
okay.
he. So if you want to know so can you please punch his voice loud and clear for all of you? A 26-year-old woman in her second trimester, you want to know the fetoplacental insufficiency. So what is the best hormone to follow, doctor? Estriol, right? Now, a postmenopausal woman has elevated estrogen. Which estrone is predominant? Postmenopausal, one. Estrone, one female. Estriol in fetus. Triol, three. Husband, wife, and fetus. And diol is during reproductive life, regular one. A young woman develops DVT after receiving estrogen-based OCPs. What is the reason? Because estrogen increase the clotting factors and decrease the antithrombin 3 that lead to hypercoagulability. Now, the next table is once more estrogen, estriol, and HCG. Most of these things are all we have discussed. So, HCG, let us start. What is HCG biochemically? Glycoprotein hormone, and it is structurally similar to LH, FSH, and TSH. The HCG's alpha subunit is shared by LH, FSH, and TSH on the chromosome number 6, whereas the beta subunit is specific to pregnancy. It is encoded by chromosome number 19. So, how do you detect the HCG? We have fluorescent immunoassay, radio immunoassay, ELISA. Their sensitivity is different. FIA is very high, right? Now, a 26-year-old, 24 weeks gestation undergoes evaluation of fetal well-being. I think this already we covered, right? Estriol. A patient has elevated thyroxine levels during pregnancy without symptoms of thyrotoxicosis. What is the likely cause? So in pregnancy, estriol is being produced, and estriol will induce the increase in thyroid binding globulin. So because of that, that will falsely elevate the T4 level. Always remember, whenever you are interpreting the thyroid level in the pregnancy, you need to keep a caveat that there can be a false elevation of the T4 because of the estriol induced increase in TBG is what you should remember. Urine pregnancy test detects beta HCG is what we should remember. Then HCG, the doubling time, the detection, the role, the clearance, favorite question of the examiner. So what is the HCG doubling time? Yesterday we discussed 2 days in early pregnancy. HCG will plateau, but it will keep rising during pregnancy until 16th week, 4th month. There it will plateau. And half-life of HCG is 24 hours, and it disappears from the urine in 48 hours post-delivery is what we should remember. Then after delivery, when will it return normal? Within 2 to 4 weeks. And typically in abortion, 4 to 6 weeks it will return normal. And in molar pregnancy, it remain elevated for a longer period. Molar pregnancy, HCG levels, up to more than 9 weeks. So what is the peak HCG? By 8th to 10th week, around 1 lakh to 2 lakh milli international units per ml is the peak. Thank you. On చేశారా ఇది వచ్చిందా రైట్ గ్రేట్ మీ పేరేంటి పురుషోత్తం వెరీ గుడ్ అందరి పురుషులలో ఉత్తముడైన పురుషోత్తముడా గుడ్ థ్యాంక్ యూ నౌ HCG rises 8 days post ovulation, doubles every 48 hours, right? So now doctor, just to take a chance to review all this numericals loaded onto your head. Very important. There is a correlation between the HCG level and some of the events. Favorite question. When will you see the gestational sac? when the HCG is more than 1500 transabdominally, and when the HCG levels are typically 6000, when transvaginally you are able to see the gestational sac visibility. Yolk sac visibility when the HCG is more than 7000. Fetal pole will be seen when the HCG is more than 5000. Cardiac activity you will see when the HCG is more than 17,000. So there is a relation between the HCG levels and the various obstetrical events, right? So it will peak by 16th week. Once more at 32nd week, there is a secondary peak of the HCG levels in the pregnancy. A woman presents with amenorrhea for 5 weeks and transvaginal shows no gestational sac. Beta HCG is 4000. What is the next step? Gestational sac, for it to appear, at least HCG should be transvaginal ultrasound 6000. So go to the 4000, but it is too early. So ask the woman to come back after 1 week. By that time, it will be 6000 and it can be seen. A patient presents 2 weeks post-abortion with persistent nausea, high HCG levels. So what is it because of? That residual, after abortion, there will be some amount of trophoblastic tissue that is continuing to produce the HCG. That is the reason she is having the nausea, which is generally the sign of pregnancy. Why pregnant women get nausea? Because of the HCG's influence. Women with severe vomiting, no fever at 9 weeks, pregnancy is evaluated. Blood show very high beta HCG. What is the diagnosis? Hyperemesis gravidarum. What is the vitamin that we give in hyperemesis gravidarum? That's what I like about you. I thought you will do wrong, but you did right. Chalu, ante. So basically, the one who doesn't have retention, the one who is not able to this thing, he need 4 or 5 times to read. The one who has been gifted with, they all come, some things will come by birth, some things by our attention, some things by determination. It's a mixture of all that makes us successful ultimately, right? Good. I'm happy to listen. Pyridoxine is given. Now, doctor, HCG, what happens in trisomy? So what is this table? HCG trends, life stages and pregnancy hormones. कितने pages हो गया? 25. 10% download over. In half an hour ante manam gantaki 50 pages లేపచ్చు. మంచి స్ట్రామింగ్ లో పోతే 5 గంటల ఖతం, ఖేల్ ఖతం, దుకాన్ బంద్. ఈ 15 క్వశ్చన్లు దీంట్లో నుంచి వస్తాయి. Now, whenever HCG in trisomy, favorite question, మీరు మళ్ళీ ఒక్క మర్తబా ప్రింట్అవుట్ చేసుకుని రివిజన్ చేయండి. Now, increased HCG levels is seen in downs. Down will cause everything fall. HCG matuku elevated. And in triple and quad test. Abnormally high HCG indicates molar pregnancy, twins, erythroblastosis, choriocarcinoma. And how high it will be? Typically, HCG more than 1 lakh milli-international units is seen in gestational trophoblastic neoplasias. Molar pregnancies around 15th week. And normally every 48 hours it is supposed to double. If it is not doubling, it indicates ectopic pregnancy, early pregnancy loss. Right? Then another difference between HCG versus progesterone estrogen during pregnancy. HCG peaks by 2 months, around 16th week. Then it falls. Whereas estrogen progesterone will peak until the end of the pregnancy. Right? Now, where do you see FSH more than LH? Childhood. In fetus, childhood, and menopause. In these phases, before menses start, menarche.
Yeah.
So childhood, fetus low, menopause low, FSH more than LH. But adult female pattern, LH more than FSH in the mid-cycle. And also during menstrual cycle. menses ayedappudu, I mean during the menstrual cycle, and LH more than FSH in mid cycle. Then FSH more than LH, where do you see? Typically in menopausal women who shows high FSH, but FSH is more than LH. So normally what will happen when the ovary produce the estrogen, it will have a negative feedback on FSH production. The menopausal ovary stop functioning, no, there is a loss of the negative feedback, and that causes an increase in FSH and LH. Then so that these things try to master it, doctor. Now 27-year-old at 8 weeks gestation has serum beta HCG more than 1 lakh, uterus size larger than expected, ultrasound show no fetal parts. What is your diagnosis? No fetal parts is complete mole, some fetal parts is partial mole. That's what you need to remember. And any HCG more than 1 lakh, no fetus, means it is molar pregnancy, is what you need to remember. So which of these best explains why FSH levels are higher than LH during the childhood and menopause? In both the phases, ovary is not producing sufficient amount of estrogen. Estrogen normally has a negative feedback. If that is not there, that lead to excess amount of FSH and LH, which are the gonadotropins, is what we need to remember. A patient has a pregnancy of unknown location. Beta HCG is 2500. No gestational sac is seen on TVS. What is the diagnosis? Ectopic. So TVS should show the sac if the beta HCG is more than 2400 international units. Absence of it is an indication of the ectopic. In the one 6000 in the
6,000 for transvaginal. Yeah.
For abdominal pregnancy.
Abdominal 1500.
Abdominal 1500. This transvaginal kagudu, abdominal unali anukunta. Chuddam. Let's see. Now, HCG, HPL, early pregnancy. So, HCG in gestational disease more than 1 lakh. And in ectopic, it is low and plateauing HCG. No gestational sac on TVS. Then what is HPL? HPL ante? Check in me Google. Full form of HPL.
Human placental.
Placental lactogen. Human placental lactogen. What does it do? This is basically produced by the placenta. It increases the insulin resistance. It increases lipolysis. It stimulates insulin production. That is a function of HPL. So who produced the HPL? Syncytial trophoblast produce a HPL. All right. Then already we finished Erystella's reaction. It is induced by progestin. So what are all the conditions where the Erystella's reaction is seen? Pregnancy, ectopic pregnancy, gestational trophoblastic disease with annitla kuda. It is a benign progestin-induced change in the endometrium, which is called as Erystella's reaction, is what we need to remember. Right? Now, doctor, let's take a couple of questions. 28-day-old woman, 9 weeks gestation, her HCG is more than 1,50,000. Snowstorm appearance is seen. Ultrasound is showing snowstorm, which is feature of molar pregnancy. Without fetal parts means it is a complete mole. Which endometrial change do you expect in gestational trophoblastic disease and ectopic pregnancy? Erystella's reaction is seen in GTD, ectopic pregnancy, and with the progestin therapy is what you need to remember. Mithuna is saying?
So opposite.
TVS is 1500, correct. Transabdominal is 6000. Ante kada. TVS more sensitive.
Yeah.
Koncham HCG unna kuda pattukuntundi. There is a small change. Thank you, Mithuna, for a. Mithuna is our most favorite student. expected to be a top obstetrician in Hyderabad. Very good, Mithuna. Huh? So always early morning is best time. Kada? We miss the bus.
Yeah.
We started early morning because ఈవినింగ్ అయ్యేప్పటికి పేషెంట్లు అంత అలసిపోతాం.
Yeah.
అండ్ మనకు కూడా క్రికెట్ మ్యాచ్లు చాలా ఉంటాయి కదా. సో ఇప్పుడంటే పట్టొచ్చు. ఇంత కంఫర్టబుల్ ఉంటే మధ్యలో కాసేపు పండుకోవచ్చు కూడా. పండుకోవాలి, లేవాలి, చదవాలి, పడుకోవాలి, వెళ్ళాలి, చదవాలి. 20 రోజులు అట్లా ఫైటింగ్ చేశారనుకోండి, వచ్చేస్తుంది సీట్. వాట్ ఈస్ ద ప్రైమరీ ఫిజియలాజికల్ రోల్ ఆఫ్ హ్యూమన్ ప్లాసెంటల్ లాక్టోజన్? It will increase the insulin resistance. It lead to lipolysis. So these are all the things effect of it, right? And HPL induces insulin resistance and in the mother and makes the mother to not use the glucose and glucose to be used preferentially by the fetus. A 24-year-old woman has ovulation on day 14 of her cycle. When will the implantation occur? 6 days post fertilization, right? Then a home pregnancy test is most reliable after how many days post conception? 14 days is what we need to remember. Home pregnancy test and urine dipstick test. The next table is adaptations in pregnancy. దీంట్లో అన్ని కూడా వాల్యూలు ఉంటాయి. ఇవి గుర్తుపెట్టుకుంది తప్పదు. The weight of the uterus, non-pregnant, is 50 grams, become 1 kilo by term. And placenta weighs how much? 500 grams, half kilo placenta, 1 kilo uterus. Maternal weight, how much mother is expected to gain the weight during pregnancy? The average gain is 12.5 kg. Then there are certain microsomal enzymes in liver, CYP enzymes. CYP2D6 is increased expression. CYP1A2 is decreased expression in pregnancy. The portal blood flow increases, blood volume increases by 40 to 50%. When will the blood volume maximum increase occur? By 32 to 34th week, a woman is in her full moon day ocean. Then coagulation factors will increase except factor 11 and 13. But still, because of this high clotting factors, pregnancy is a hypercoagulable state. The heart rate increases by 20%. Cardiac output increases by 40%. BP, SBP decreases, diastolic BP very much decrease, more than the SBP. Why? Because pregnancy produces progesterone. Progesterone leads to smooth muscle relaxation of the blood vessels, leading to the development of the intense vasodilatation, which will decrease the diastolic BP, whereas the mean arterial pressure is unchanged. Systemic vascular resistance decreases, but central venous pressure is unchanged. So what changes, what doesn't change, which changes more than the other? Examiner, chodega nahi. The apex beat become displaced into the fourth intercostal space. And lung volume. Why it will apex beat will display? Because intra-abdominal pregnancy will push the diaphragm up and heart will displace. Lung volume, favorite question. Tidal volume increases, PO2 increases, minute ventilation increases, but expiratory reserve volume, residual volume, it will decrease. Then VC, vital capacity entry. So in lung volumes anni kuda telusu kada. Tidal volume ante basic volume without forced inspiration or expiration, 500 ml. Tidal volume increases, PO2 increases, and progesterone will go and stimulate the respiration. Respiratory rate increase. Minute ventilation ante enti? Tidal volume into respiratory rate. So the minute ventilation increases, ERV decreases, but we see unchanged. Examiner's favorite question. Then because of that hyperventilation under the influence of the progesterone, it leads to mild respiratory alkalosis. GFR increases, Renal plasma flow increases, kidney length increases, but serum urea creatinine decrease. Iron profile, very important. Pregnancy la. Serum ferritin decreases, serum iron decreases, TIBC transferrin, both of them will increase. Endocrine changes. Growth hormone increases, ACTH increases, prolactin, T4, insulin, all of them will increase. And also there is an insulin resistance. ఇందులో నుంచి ఒక్కటి పికప్ చేసి ఇది పెరుగుతుంది ఇది తగ్గుతుంది ఇది పెరుగుతుంది ఇది తగ్గుతుంది ఎగ్జామినర్ విల్ ప్లే విత్ అవర్ లైఫ్. ఆల్రైట్, గుడ్ టు సీ 5 ఆన్లైన్ క్లాస్మేట్స్. వెరీ నైస్ డాక్టర్. ఎవ్రీ డే ఎర్లీ మార్నింగ్ 5 o'clock to 9 o'clock బ్రహ్మ ముహూర్తం. I will give you a notes, secret notes. Sure shot. All questions will come only from these notes. You don't need any other notes. That's my promise to all of you. Right? So please do come every day morning by sharp 5 o'clock. And we will make it happen. Now, doctor. 26-year-old woman, 30 weeks gestation, presents for routine follow-up. Her hemoglobin 10.2 with decreased serum ferritin, increased TIBC. What is the cause of her anemia? It is physiological hemodilution that occur in pregnancy because more plasma volume increase than the increase in RBC volume. Pregnant woman in her 3rd trimester complains of occasional palpitations, loud S1, systolic murmur, S3 is noted. What is the likely explanation? So it is a normal physiological change. Normally S3 is indicative of heart failure. S4 is indication of hypertrophic heart, which is not elastic. So ikkadenti pregnancy lo matuku it is a normal physiological thing. Endukante heart is receiving 40% increased volume. ఎంత మంచి హార్ట్ అయినా ఎక్కువ చదివింది అనుకోండి కూర్చుంటుంది కింద. రైట్, ప్రెగ్నెన్సీ ఇస్ లైక్ క్రాష్ కోర్స్ బిఫోర్ ఎగ్జామ్. రైట్, 28-year-old pregnant woman undergoes pre-operative evaluation before elective cesarean. So గుర్తుపెట్టుకోండి, what will you have? CYP1A2 decrease, 2D6 increase in pregnancy. Now doctor, pregnancy adaptations, once more, continues the story. There is a systolic murmur which is physiological, seen in more than 90% of pregnant women. BMR increases by 10 to 20%. How much calories, kilocalories per day increased requirement is there because of the pregnancy? Normal people require 1500 to 2000 kilocalories అయితే pregnant women లో fetus కూడా తింటాడు కదా. Chotu also will be eating food, no? Yeah. So plus 350 kilocalories per day. Both ESR increases, total WBC count increases. All clotting factors increase except the factor 11 and 13, don't forget. Albumin will decrease because of hemodilution. Albumin globulin ratio, normally 1:3. I mean 3:1. That will almost come to 1:1. Because in pregnancy, globulins increase. Instead of 3:1 albumin globulin ratio, it will become 1:1. There's an increased TIBC, increased transferrin, decreased serum iron and decreased ferritin. Increased T4, increased TBG, BMR increases, but the free T3, T4 are normal. PDH levels decrease in first trimester and then increase later in gestation. Calcium, total calcium will decrease, but ionized calcium will remain the same, and there's an increased calcitonin. Prolactin will increase progressively, it will reach 10x normal. Then insulin resistance will be there. And 2 hormones, ACDH, PTH, they do not cross the placenta. There is one important entity I can never forget. Peripartum cardiomyopathy. After I had one patient coming from Mehboob Nagar, after delivery of twins, she had a dilated cardiomyopathy in the postpartum period. She didn't survive. Same time, twins became orphans. I mean, lost their mom. Yeah. So dilated Cardiomyopathy, very common, is possible after pregnancy. It develops in the last months of pregnancy and within 6 months postpartum also in some people. Postpartum psychosis will occur, and that will occur within 6 months of delivery. So expect your wife to get psychotic when your son is born. Huh? So postpartum blue ante is not psychosis. It will typically peak 3 to 5 days postpartum. Only 3 to 5 days. That time the mother will be thinking, maybe my kid will not go to medical college, he will not study physics very well, something like that. Maybe he has, మన డాక్టర్స్ అయితే ఇంకెక్కువ ఉంటుంది. Our doctors will suffer more blues. Maybe my baby has ASD, maybe my baby has VSD. All entrance MCQs will appear in the newborn baby. Right? So it peaks 3 to 5 days postpartum because of the low estrogen progesterone. All right, doc? So just be sure on this table. Okay? Then, 30-year-old pregnant woman has increased caloric intake and BMR. Total T4 elevated but free T3, T4 normal. What is the reason? Because of the high estrogen, there is an increased TBG, which is responsible. Woman develops heart failure symptoms 2 months postpartum, echo show global hypokinesia. EF has gone to 35%. What is your diagnosis? Peripartum cardiomyopathy is the one which need to be remembered. A pregnant woman at 36 weeks has a mild glycosuria on routine urine analysis. She is asymptomatic. Her serum glucose is normal. What is the next step? Glycosuria is common in pregnancy because of increased GFR and decreased tubular reabsorption of the glucose. Glycosuria will occur. Right? Next, doctor. We finished all this. There are certain signs of pregnancy. Goodell sign means what? Cervix gets softened because of increased vascularity. When will it appear? 6th week. What is Hagar sign? The uterus becomes soft, felt during bimanual examination between 6th to 10th week. Cervical softening, Goodell. Uterine softening felt during bimanual exam is 6 to 10 weeks. And a 28-year-old pregnant woman at 7 weeks of gestation has a palpable lateral bulge of the uterus on bimanual examination. What is this called? It's called Piscusek sign. It's a palpable lateral bulge or a asymmetric uterine enlargement to occur by 6th to 8th week. Fetal growth factor. So, which hormone maximally affects the fetal growth? Insulin. Insulin is anabolic hormone. It is the insulin which will make the fetus grow into what it is today. Then lactation suppression. In pregnant women, despite high prolactin levels, lactation fails to initiate. What is the cause? In postpartum women, high prolactin undi. Kani lactation fails to initiate. So basically, estrogen and progesterone inhibit the prolactin's action during pregnancy, suppressing the lactation. Ante high progesterone estrogen plus high prolactin unte pregnancy lo no lactation. Post pregnancy only high prolactin, no high estrogen progesterone. Hence lactation. Now, what stimulates the prolactin? Basically, dopamine inhibits prolactin. Antipsychotics inhibit dopamine. That's the reason antipsychotics promote prolactin. Like haloperidol, increase the prolactin by dopamine antagonism. Diazepam, like anxiolytics, benzodiazepines, increase the prolactin. TRH and testosterone increase the prolactin. So, ఒకసారి చూసుకోండి. Pyridoxine suppresses prolactin. Levodopa is a dopamine agonist used in Parkinsonism. It will inhibit prolactin. Atla, what are the different things that affect the prolactin? Then coming to breast. The development of the breast includes growth of the lobules and alveoli. And a part is ductal branching. So, you want a break? Fine, huh? Good. ఎంత అయింది గంట
110.
110. Good. So good. Now, the branching of the ducts is caused by estrogen growth hormone and adrenal steroids, whereas the lobule and alveolar growth is by progesterone, prolactin, estrogen growth hormone. There is a difference between the two. Got my point?
Yeah.
So, then production of milk is by prolactin. Ejection of milk is by oxytocin. Okay. Now, a 30-year-old woman delivered a healthy baby 2 days ago. Despite frequent breastfeeding, she reports poor milk secretion. She has a history of schizophrenia, currently on haloperidol. Anangan duki embetal answer. Prolactin suppressed by her. Dopamine. Prolactin is increased. Dopamine antagonist changes the
Should stimulate prolactin.
stimulate, no?
Yeah. Yeah.
ఇది కొంచెం రాంగ్ ఉంది ఫ్రేమ్
Okay.
రివర్స్ ఉండాలి.
Right.
35-year-old on cabergoline for galactoria.
Paradoxically, the explanation. Haloperidol.
Increases prolactin,
Paradoxically.
haloperidol,
Yeah.
but paradoxically disrupt the physiological lactational rhythm. Anyway, we'll check it. It's a postgraduate level question.
Okay.
A 35-year-old woman is prescribed cabergoline for galactoria. So what is the mechanism of action of this drug in treating the hyperprolactinemia? So basically, cabergoline is
Dopamine. Increases dopamine.
cabergoline is dopamine receptor agonist.
Okay.
That's the reason it will cause the suppression of prolactin. A lactating mother is administered pyridoxine. Huh?
Yeah.
So, pyridoxine ఏం చేస్తుంది? Supplements. So it will, pyridoxine suppresses the prolactin synthesis. Huh? Now, quickly, intrauterine devices is our next table. Now, mainly you need to know what are the different devices, what is their lifespan, and what are the special advantages. Copper T380A, 10 years is the lifespan. Copper T380A is safe in nulliparous women, nulli gravida. Gynifix, it is a frameless 4th generation IUD with 6 copper cylinders on nylon thread. And what are 3rd generation IUDs? Hormone releasing IUDs like Mirena, Progestin, Surt. They all release the hormones. So what does Progestin Surt will release? Progesterone, and it inhibits the ovulation, it thickens the mucus and lead to contraception. Mirena releases levonorgestrel, and it is also used in emergency contraception. Then, if you look at the copper IUCDs, Cu 250 by 375, it lasts for 3 to 10 years. Right? Then, always you need to screen for pelvic inflammatory disease before placing the intrauterine contraceptive device. Now, doctor, 27-year-old multiparous woman wants long-term contraception. No history of STDs and is in monogamous relation. What is the best one? copper 380A. For nulliparous, nulligravida. It is the best one. 22-year-old nulligravida woman is given a long-acting IUD. Gynecologist mentions a frameless device, which is Gynifix. The woman complains of irregular bleeding and desires contraception with added benefit of menstrual control. Levonorgestrel containing Mirena, right? So it will also control the irregular bleeding, not only contraceptive effect. Next, hormonal IUDs. Next table. Levonorgestrel, how does it act? It is a progesterone. It thickens the cervical mucus, causes anovulation. Mirena contain how much levonorgestrel? 52 milligrams of levonorgestrel, and it releases 20 micrograms per day, and it will be lasting for 5 years. In 3 numbers గుర్తుపెట్టుకోవాలి. Skyla contains 13.5 milligram levonorgestrel. It has a shorter duration. Then progestasat, how much it will release? 65 micrograms for progesterone, and its span is for 1 year. So quickly remember, copper 380A 10 years, Mirena 5 years, MLCU 375 5 years, CUT 200 is 400, 4 years, and progestasat is 1 year. So what are the non-contraceptive advantages of the IUCDs? Menorrhagia, endometrial hyperplasia, fibroids, endometriosis, all these things, the hormone containing IUCD, third generation, releasing progesterone is useful. Then in Asherman syndrome, after endometrial dilatation curettage, there are adhesions formed. They present with secondary amenorrhea. So to treat that also, we use the IUD. IUD is used after adhenolysis. Then what is the most common cause that you needed to remove the IUD? Pain is the most frequent cause. What is the commonest side effect of IUD? Bleeding. Average blood loss is about 80 ml. Most common infection with IUD? Actinomyces. And how do you investigate the missing IUD? Ultrasound. And if there is a previous pregnancy, ectopic pregnancy, is it against putting an IUD? It is not a contraindication, but IUCD can predispose to ectopic. ఎందుకంటే యూట్రస్ కంఫర్టబుల్ లేకుంటే పోయి ఫాలోపియన్ ట్యూబ్ లో కూర్చుంటుంది. Absolute contraindications. PID, genital TB, unexplained bleeding, and suspected pregnancy. Specific contraindication, Wilson's disease for copper T and breast cancer for Mirena. And what is the best time to insert IUCD? Within 7 days of menstruation, post-termination, or more than 6 weeks postpartum with 7 days contraception. Right? That's the insertion timing. Clear, doctor? Now, enter number 47. Oh, 20% download over. Yeah. 2-minute voice break. Now, 35-year-old women with heavy menstrual bleeding, fibroids want long-term contraception. Whenever menorrhagia is there, it is always preferable to put a LNG, that is Levonorgestrel IUD. A patient returns with lower abdominal pain 10 days after IUD insertion. What is the cause? Actinomyces, most common infection. The gynecologists want to confirm the position of the IUCD, which is missing. Ultrasound. Now, oral contraceptive pills. Mark my word. Favorite question. Definitely one question will come.
Yeah.
What are the 3 cancers incidence decreases by giving OCP? Ovarian, endometrial, colorectal. Then fibroadenoma is also called breast mouse,
Yeah.
because only the woman has to catch and show you. You can't catch.
Right.
That also decreases the risk in if you take OCPs.
Yeah.
OCPs decrease the pelvic inflammatory disease risk but increase the candida vaginitis. OCPs help in dysmenorrhea. Dysmenorrhea is pain during menstruation. Ovulation lead to dysmenorrhea. Old time grandma used to say, if the granddaughter is having abdominal pain during menses, you will produce a lot of children, she used to say. So because dysmenorrhea is an indication of
Okay.
ovulation. So OCPs help in dysmenorrhea and cycle control. OCPs decrease the risk of ectopic pregnancy. Functional ovarian cysts are decreased. Because OCPs induce amenorrhea, they decrease blood loss and decrease anemia. OCPs decrease the size of the fibroids. And OCP contain estrogen. That's the reason they decrease the osteopenia and osteoporosis. But OCPs increase CA cervix. They increase the breast cancer risk is what we should remember. They increase the hepatic adenomas, pituitary adenomas risk, thromboembolism risk. They will cause the stasis of the gallbladder leading to gallstones, cloasma, breast tenderness. They increase the risk of chlamydia, candida infections. And OCPs can lead to depression that can be improved by giving vitamin B6, your favorite, right? So ఇదంతా ఓసిపిలతో ఏం జరుగుతుంది, తగ్గుతుంది, పెరుగుతుంది, తగ్గుతుంది. You need to master this. 32-year-old women on combined OCPs reports improvement in her acne. What component is responsible for this benefit? Third generation progestins help acne and hirsutism because they are anti-androgenic. A woman using OCPs for contraception presents with sudden shortness of breath and chest pain. What side effect is likely? Embolism, increased clot risk, especially age more than 35. 26-year-old women on OCPs develop galactorrhea, amenorrhea. She is found to have a liver mass. Hepatic adenomas are common in OCPs. Now, the next table is about contraindications and mala pills. Let's talk about it. So, what is an absolute contraindication to give OCP? Uncontrolled hypertension, history of thromboembolism. Similarly, migraine and focal neurological deficits like hemiplegia, etc., absolute contraindication. Coronary artery disease, heart attacks, cerebrovascular disease, stroke, absolute contraindication. Then breast cancer is absolute contraindication. Undiagnosed uterine bleeding, like dysfunctional uterine bleeding, double, absolute contraindication. Age more than 35 plus smoker, absolute. Then what are relative? Examiner is very specific. What are relative? What are absolute? Hypertension, diabetes, obesity, migraine without ARA, SLE, seizures, relative. Migraine with aura, without aura.
Yeah.
Is relative. Then infectious hepatitis, like viral hepatitis, liver dysfunction, contraindication. And among the progesterones, OCPs, the one containing drospirenone has a higher risk of DVT and pulmonary embolism. Then what is Mala N and Mala D? Should know very clearly. They contain 30 micrograms of ethanyl estradiol plus 0.15 milligram of levonorgestrel plus 7 iron tablets. Mala N is given free of cost by Government of India. Mala D at subsidized price by a Hindustan Latex FP Promotion Trust. So what is the day to start the OCPs? Day 5. And if, common question, if she missed one pill, take 2 pills as soon as possible. If you missed one class in crash course, take 2 classes. Then OCPs reduce the efficiency of anti-epileptics. And OCPs don't give them in the first 6 months of breastfeeding. SLE is a relative contraindication to OCP. So on this MCQs will come. So age more than 35, smoker is absolute contraindication. Similarly, migraine with focal neurological deficit, absolute contraindication.
Yeah.
If missed one, take 2 pills, is up. Right?
Yeah.
Next comes Saheli, OCP doses, triphasic pills and drospirenone. Is a rapid revision table. Right? So good to see 3 online classmates, 4 online classmates. Please punch is the voice loud and clear for all of you, doctor. Right? Yeah. Every day we have early morning 5 o'clock to 9 o'clock. Rapid crash course, 1 subject 1 day. మనం ఎన్నైతే అన్ని 9 కల్లా కొడదాం. మిగతావి you should promise.
Yes, sir.
That you finish logically till the end of it.
Yeah.
ఇప్పుడు ఎక్కడికి వచ్చినాం మనం ఎన్నో పేజ్?
55.
55 అనుకోండి. నేను కనీసము ఐఎమ్ షూర్ 200 వరకు దాన్ని ఖతం చేసిపోతా.
Okay.
ఇంకా 50 మీరు కొట్టేయాలి.
Yeah.
కొట్టేసి ఫుల్ స్కేల్ మాక్ టెస్ట్
Yeah.
తీసుకుని
Yeah.
రిజల్ట్ నాకు చెప్పాలి.
Yeah.
అందులో తప్పులు ఏమైనాయి అనేది కూడా చెక్ చేసుకోండి.
Okay.
దెన్ వీఆర్ ఆన్ ట్రాక్
Yeah.
ఫర్ ద ఎగ్జామ్. అండ్ ఇందులో మీరు 250 పేజెస్ రివైజ్ చేసేటప్పుడు యూ ట్రై టు టిక్ వాట్ ఐఎమ్ గోయింగ్ టు ఫర్గెట్, హౌ ఐ కెన్ రిమెంబర్ రిపీటెడ్లీ అని. మళ్ళీ రేపు నిన్నటిది అయిపోతున్న కొద్ది సబ్జెక్టులు ఆ టిక్లు పెట్టుకుంటారు కదా, వాట్ యు ఆర్ ఫర్గెటింగ్, అవి ఒక్కటి రోజు రివైజ్ చేయండి. అప్పుడు ఆటోమేటిక్ వస్తుంది సీట్. 20 दिन काफी है भाई, उससे ज्यादा पड़े तो जान की खतरा. Right? 20 days ముందర what మనము we have to play cricket, we have to play football, all is good. అట్లని చదవాలి. If you get frozen during that time, ఈ లాస్ట్ 20 days లో స్టామినా ఉండదు. ఈ లాస్ట్ 20 days you should be like a laser, you should burn the paper. Now, missed 2 pills, use backup method plus continue pills. Then, if you stop OCPs, when will fertility come? 3 months. What is Saheli? It is a weekly non-steroidal pill containing centachromon.
It's a
Contraceptive, Saheli. Ormiloxifene, clomiphene, ormiloxifene, ఇవన్నీ సెలెక్టివ్ ఈస్ట్రోజన్ రిసెప్టార్ మాడ్యులేటర్ is there. That's how Saheli works. What is the schedule of Saheli? It is a non-steroidal, but it does not contain estrogen, it does not contain progesterone. It contains, in fact, selective estrogen receptor modulator called ormiloxifene is Saheli. How frequently you will give? Twice per week for first 3 weeks, then once per week. Then centochromone also, estrogen antagonist. It is a non-hormonal concept. Now coming to OCPs. OCPs, like you have high dose, low dose, very low dose. High dose means more than 50 micrograms of ethinyl estradiol. Low dose means 35 micrograms. Less than 20 micrograms of ethinyl estradiol is very low dose. And minimum dose is 10 micrograms undale for it to act. Then what is a triphasic pill? It contains ethinyl estradiol, levonorgestrel, right? And it is given in 3 phases. Just like a normal menstrual cycle, estrogen levels will vary,
Yeah.
The same way it will follow. Triphasic is because you want to dose the high dose of estrogen throughout. You will sequentially increase the dosage in triphasic pill. That way it is safe in diabetics, minimal effect on lipid and glucose metabolism. So what is the triphasic dosing? It is 11 ethinyl estradiol, 30, 40, 30. Levonorgestrel 50, 75, 125 over the cycle. That is triphasic secret. And why to unnecessarily expose to high dose of estrogen throughout the menstrual cycle and the fundo behind triphasic. So what is Femilon? Ethinyl estradiol plus disogestrel 0.02 and 0.15. What is Novilon? Ethinyl estradiol, disogestrel, but 0.03 is ethinyl estradiol. Then what is Today? Today is a condom. It contains 1 gram nanoxynol and it is effective for 24 hours. Other nanoxynol and untadi. It will make a sperm die. So Today condom. Today is the name of the condom. Then drosperinone. It is one of the progesterones. It is similar to spironolactone. Spironolactone is aldosterone receptor antagonist. It has no weight gain, bloating, or hypertension. That's the advantages. So acne unna, PCOS unna, hirsutism unna, hormone replacement therapy lo, you want a anti-androgen effect. Which progesterone is used for that purpose? Drosperinone. Then what is Yasmin pill? It contains ethinyl estradiol with drosperinone. Drosperinone is like spironolactone, anti-aldosterone. That's the reason no water retention or hirsutism, which is often seen whenever you are using only purely other progesterones. Once a month pill contain what? Quinestrol. So quinestrol plus short-acting progesterone. What does mini pill contain? It contains only progesterone. It's POP. Why? It is very effective in breastfeeding women. If you use a combined OCP in a breastfeeding woman, that will affect the lactation, interfere with the lactation. Hence, we use POP, progesterone only pill. What is that non-steroidal and estrogen antagonist in action? Centochromone. What is that? Ormiloxifene, non-steroidal weekly pill. Which newer progesterone containing pill is best if the woman is having weight gain, bloating and acne, if she is on combined OC pill? Yasmin. It contains ethinyl estradiol plus drosperinone with minimal water retention and hirsutism. A patient asks about safety of contraceptive pill, which is safe in diabetic women. Triphasic pill, because it has a better metabolic profile, 30, 50, 30, estrogen part. Then that is the story, doctor. Next comes POPs and contraceptive implants is our next table. Now, where do we use POPs? Very good. Micronor contain norethindrone 0.35 milligram daily POP. Ovret omelette gal, overate. Norgestal 75 micrograms, daily POP. Sirajet, it is a new POP with disogestrel, 75 micrograms, daily use. The Norplant is a intrauterine contraceptive device containing 75 milligram levonorgestrel, 6 rod implants, but it is obsolete now. Norplant 2, it contain only 2 rods and 3 years duration. Uniplant contain novigestrol 1 year action. Implanon contain single rod. They are all implants.
Yeah.
It contains etonorgestrel 68 milligrams. Implanon lasts for 3 years and releases 60 micrograms per day. Then what is Capranor? It is a biodegradable LNG capsule implant. IUCD gal,
Yeah.
implant. Gossipol is a male contraceptive pill which is under trial, which will decrease the spermatogenesis. I mean, anti-sperm. Then low dose pills contain disogestrel. And always remember, IUD users the high ectopic pregnancy. That's difference. OCP protects against ectopic.
Yeah.
IUCD promotes ectopic. So both of them are contraceptives.
Yeah.
Clear?
Yeah.
Then quickly, questions. I leave it for you to review the questions. Now, doctor, the progestine's barrier methods, vaginal rings. अंत बट्टी गोटे रट्टा मारने वाला आइटम्स ज्यादा रहता ऑब्स्टेटिक्स में.
Yeah.
But there is no choice. So nice to see 4 online classmates every day, early morning, 5 a.m. to 9 a.m. Dr. Murli will be with you to revise, right? So please join. Sleep early, wake up fast. Is my voice loud and clear for all of you? Please punch. Now, very good. And the run rate ఎంత ఉంది? 58, huh?
Yeah.
Okay. Let's go fast on the train. Dipomedroxyprogesterone acetate. 150 milligram IM every 3 months injection. DMPA is used within 5 days of menstrual cycle. And postpartum also, during lactating time also, you can give the DMPA is safe. Similarly, epilepsy unaguda DMPA is safe. Then Noristerat, it is another dipoprogestin every 3 months sister. So the net EN, norethistron, typically 200 milligram IM every 2 months. Now, what is the most common side effect of this dipomedroxyprogesterone acetate? Irregular bleeding. Favorite question. And what is the common side effect of DMPA? Weight gain. It takes 5.5 months to return fertility after you stop DMPA. Right? Then Nirod is the condom. Most common cause is improper usage and slipping of the condom. Right? And the condom failure rate is 2 to 3 per 100 women years. Right? Then what is femidom? Femidom is the female condom. It is made up of polyurethane. And they can also place a vaginal sponge, which release the nonoxynol 9, which will kill the sperm. Then you have SVR ring, Nova ring, and a ring form, cielistic ring. It releases 20 milligrams of levonorgestrel daily. Nova ring is 15 microgram ethinyl estradiol plus 120 microgram of etonorgestrel is Nova ring. ఇవన్నీ బట్టి వాడిన పడతా. ఫేవరెట్ క్వశ్చన్స్ ఇవన్నీ ఎగ్జామినర్కి. కొన్ని ఉంటాయి ఫస్ట్ టైం కన్ఫ్యూజింగ్ ఉంటాయి ఆల్ టర్మ్స్. कैसे भी कोशिश करना, because out of 30 questions, doctor, at least 3 questions come from contraceptives and IUCD. We are falling short by how much? 10 marks only, no?
10.
10 ఎట్లా కొట్టాలంటే ఇట్లా ఆ 10 వస్తేలేండి ఈ 20 days 20 into 4 80 hours
Yeah.
ఎఫర్ట్ తోటి ఆ 10 కవర్ అయిపోతాయి నా ఆశ. సో ఇదిగోండి, sickle cell anemia, you want to give long term contraception. For sickle cell disease and epilepsy, best is DMPA, dipomedroxyprogesterone. She asked about failure rate of condom, 2 to 3 per 100 women year. Then Nuvaring lemuntai, ethinyl estradiol and etinogestrol will be there, right? Then that is a story, doctor. Next comes natural methods, emergency contraception, etc. Clear, sir. Mithuna says clear voice. Very good. 2-minute voice break idam. Very good to see around 6 online classmates. Excellent, doctor. Now, what are the natural methods? Rhythm method, avoid intercourse during fertile window. And what is fertile period? 18 days from the shortest period, 10 days from the longest cycle. And if you take two components, post-ovulatory, pre-ovulatory. So, depending on, some women will have 35-day cycle and some women will have 25 days cycle. So, 18 days from the shortest and 10 days from the longest cycle is considered to be the fertile period. Now, Spinberg kit we finished already. Huh? It is typically what stretchability of the cervical mucus, which is the effect of estrogen. So a woman can test whether the cervical mucus is thick or watery. If it is watery, it is estrogen. If it is thick, it is progesterone. Accordingly, progesterone thickness undankondi, unte ovulation happened, she will know. Huh? Then yeah. Now, ఇది ఒకసారి రివ్యూ చేయండి ఇదంతా. A woman exclusively breastfeeding her 2-month-old infant had no period since delivery. She is using lactational amenorrhea as contraception. Is it correct? Yes, definitely. A woman uses the Billings method of contraception. She notes a clear, thin, stretchable cervical mucus. What is that phase? It is the typically Spinberg kit is estrogenic mucus. Means she is pre-ovulatory and ovulatory phase. And maximum estrogen will come just before ovulation. No?
Yeah.
Then it becomes estrogenic mucus become thin. A woman takes contraceptive, emergency contraception. What is the main mechanism of action? It inhibits the ovulation, it inhibits the fertilization. Okay. Now, let's go to the next table on emergency contraception and tubectomy. Some favorite points are there. Emergency contraception is effective within 72 hours. So 1.5 milligrams single dose or 0.75 milligrams into 2 doses most commonly used. What is Ujpase method? It uses combination ethinyl estradiol plus levonorgestrel in double dose, 12 hours apart. So there is overall G, Mala D. You take 4 stat and 4 after 12 hours, 4 tablets. That is tab Mala, Ujpase method. Include, you can also give high dose estrogen. I told you, high dose, low dose, very low dose means what? Minimum, how much dose should be there? Estrogen 10. High dose estrogen is also effective, but more side effects. Then mifepristone. Mifepristone, misoprostol. Mifepristone is antiprogesterone. RU486 it is called. 10 milligram dose works up to 49 days last menstrual period. Then what is ulipristol? So it is a progesterone, 30 milligram, approved for emergency contraception up to 120 hours. Then ulipristol is also used to shrink the size of fibroids. I mean, if fibroids are there, ulipristol is used in 5 milligram dose. Then mifepristone and misoprostol. It is a method used for MTP up to how many days? 49 days. Mifepristone plus tamoxifen can be used up to 63 days. So what is the MTP protocol? 600 milligram day 1 is mifepristone plus misoprostol 400 micrograms on day 3. Misoprostol will eject, mifepristone will dislodge. Antiprogesterone is taken, the implant get dislodged. Progesterone support नहीं है तो मिसोप्रोस्टॉल क्या करेगा, पूरा यूट्रस को कंट्रैक्ट करके उसको बाहर निकाल देगा. So when do you start the OC pills? Start on day 1 or day 5, right? So next, tubectomy. What is the most common method of the tubectomy postpartum? Pomeroy method. What is the importance of postpartum? Always propose the idea of tubectomy to the woman after delivery of a child. Amma, I don't want any more NEET PG entrance, she will say. Right? Enough is enough. This 1 year was the time where with all my kid and all. That's the best time. Mauke pe chauka maro. Huh? So Pomeroy method. I mean, you will do the tubectomy. Easy to convince her.
Yeah.
So many pregnancies, so many children are not worth. They will go to America, Australia, Europe, everywhere, and nobody will stay. Except the dog. So postpartum ligation is Pomeroy method.
Yeah.
Suppose tubectomy is over and after that some mishappening unfortunately happened and they want to once more produce the child. Then isthmic anastomosis has the highest success of reversal. And after doing the tubectomy, the way you try to ligate, femoral enda, isthmic enda, cornual enda. So isthmic anastomosis is the highest success that you can recanalize. Okay? That's like cancellation of flight reservation. So after reversal రావాలి కదా. So hormonal emergency contraceptive, what is the best option? Levonorgestrel 1.5 milligram. Women with known fibroids seek emergency contraception 4 days. Best way is ulipristol 30 milligram standard or 5 milligram in fibroid. 32-year-old postpartum sterilization, what is the best method? Modified Pomeroy. Then further, tubal ligation and reversal. These are the favorite questions, doctor. There are various ways by which tubectomy is done. Electrocautery, bipolar is safer than unipolar cautery to burn that. Then halka clip, most reversible but high failure rate. Uchida method, where you will cut it and then bury it into the surrounding there are a lot of parametrial tissues are there. No? Into that you will bury the cut end. It is most reversible but highest failure rate is Hulka. Uchida is most effective, no failures reported at all. Irving method is extremely low failure. Mala failure rates kuda adutaru. Ye method la endi failure rate and see, we are a populous country and these things are very important both in SPM and also in obstetrics. Kadabatti ivanni batti kottalappa. Ratta manna padta. Modified Pomeroy, Hulka method, etc., etc. Now a woman wants a reversible method of tubal ligation. What is the best chance? Halka clip, most reversible but high failure rate. History of bipolar cautery sterilization, become pregnant. What is the likely cause? Bipolar cautery has the highest failure rate than unipolar. Which method of tubal ligation has zero failure? Uchida method. Then various intratubal devices and mode of choice. You can also put a device in the fallopian tube because that is the place where fertilization occurs to avoid.
Yeah.
So what is Essur, not Trisur? Essur. Hysteroscopically, you will go and place a device into the tube, proximal part of the fallopian tube, and it will become effective after 3 months because it will need to induce the inflammation and tubal block. That is the funda. Then Ovion, Adiona, they are also intertubal devices. Now, for the lactating woman, what is the choice? Mini pill. What is that? It is a progesterone only pill containing levonorgestrel. Newly married couple, combined OCP. Commercial sex workers, barrier method. HIV positive patient, condom. HIV positive couple, both need to use the condom. Rheumatic heart disease, don't give OCP. Double barrier method. So, Essur mechanism is fibrosis induced by that device. Okay, I leave the literature for you. And please solve these questions, doctor. Now, concept of failure rates. You need to remember all this list of failure rates. ఇందులో ఏది అడుగుతాడో వాని ఇష్టం. Now, a couple asks for vasectomy, expected failure rate 0.1%. Clistic band 17.7 per thousand, which is not effective for emergency conception. We use Iliprestol, levonorgestrel, copper T IUCD, not DMPA injection for emergency. Finish. ये पूरा ट्यूबेक्टमी वैसेक्टमी का मामला खत्म. अब भी आ गया मैटरनल सीरम स्क्रीनिंग. ఎన్నో పేజ్ అండి? 75. 100 అయినా క్రికెట్ బ్యాట్ ఎత్తారు. ఇదంతా ఏంటంటే టెస్ట్ క్రికెట్, 1 డే ఇంటర్నేషనల్స్, 1 డే 1 సబ్జెక్ట్.
Coffee.
కాఫీ పీనా, చాయ్ పీనా, పడినా టెన్షన్ వస్తే అసలు మీకు జీరో టెన్షన్ ఉంటుంది. హౌ ఉంటుందా? జీరో టెన్షన్. I love zero tension guys. Anxious guys, you can't compose them. Half energy of teacher goes into composing them. ఎవరు టెన్షన్ వాళ్ళు పడాలండి.
Hello. కింద 2 cups coffee పంపిస్తాను. ఒకటి మిల్క్ తోటి, ఇంకోటి బ్లాక్.
మనం 100 days ఇట్లా చదువుంటే బాగుండేది. దేని టైం దానికి వస్తుంది. నా డ్యూయల్ మార్కర్, ట్రిపుల్ టెస్ట్, క్వాడ్రుపుల్. When do you do dual mark? 9 to 13 weeks. Free beta HCG, which is increased in downs. PAP A decreased in downs and trisomy 18. Triple ante done between 15 to 18. It includes AFP, beta HCG, and estriol. Urinary estriol. Quadruple ante triple test plus inhibin A. Increased inhibin A is a feature of downs. Edwards syndrome, all are down. Down syndrome, all are down, but not beta HCG, which is increased. Turner syndrome, beta HCG increased and metal serum alpha fetoprotein increased. Neural tube defects, MSAFP increased. And twins pregnancies lo beta HCG high untadi. And urinary estriol normal untadi. Metal serum alpha fetoprotein increase untadi. Molar pregnancy, beta HCG more than 1 lakh. If the fetus is dead, beta HCG will fall and MSAFP will increase. And what is the most specific neural tube defect marker? Acetylcholine esterase levels. Clear?
Yeah.
Now, doctor, all these questions you need to solve.
Okay. Hmm.
High free beta HCG, low PAPA,
Yeah. No.
downs. Early detection of neural tube defects, alpha fetoprotein. Molar pregnancy, beta HCG. Quadruple test, what is most important? High HCG,
Yeah. Low.
low estriol, and alpha fetoprotein. And also high inhibin.
Okay.
So now continuing the legacy. AFP, peak AFP in fetal serum is around 3 lakhs at 14th to 15th week.
Yeah.
Maternal serum AFP, it peaks by 30 to 32. Amniotic fluid AFP in early second trimester. So out of all this, increased maternal serum AFP ki most common cause enti? Incorrect maternal age dating. Last menstrual period మర్చిపోతారు. अगर LMP भूल गए तो a woman comes little late and you have done MSAFP.
Yeah.
So because that wrong dating, difficult to interpret the AFP levels.
Okay.
So that is the most common cause. But otherwise, what are the GI defects? If the metal serum AFP is increased, gastroscus and omphalocele. Similarly, anencephaly, open neural tube defects, they cause increased AFP.
Yeah.
Similarly, cystic hygroma, pilonidal sinus, ectodermal dysplasia, even other causes.
Okay.
And any fetal death or multiple gestation cause high metal serum alpha fetoprotein. Inni causes untai, MSAFP. But most common is wrong dating. So ultrasound shows anterabdominal wall defect with bowel loops outside the abdomen. What will it show? Increased MSAFP in gastroscus. Gastroscus kante pura bahar nikalta.
Yeah.
Then decreased AFP typically is a feature of trisomy 21. Adi gurtupeట్టుకోండి. High omphalocele, low downs. Spina bifida में most specific test is acetylcholine esterase. Finish. Next, fetus development timeline is very important, doctor. Okay. Now, thank you, Mitina, for the feedback. The voice is clear. I'm happy. You too have privilege. I too have privilege to walk into kitchen and have a coffee while the class is going on. So now, when will you see the cardiac activity? 6 weeks by transvaginal. Chorionic villus sampling, when will you do? 11 weeks. So, ఈ days అని కొంచెం గుర్తుపెట్టుకోండి. Fetal meconium forms by 16th week, fetal swallowing starts by 10th week, fetal breathing starts by 11th week, fetal eye opens by 26th week, and our eyes open 10 days before exam. Huh? So, lanugo hair begins at 24th week. Perception, fetus can see the light by 28th week. And engagement in primary occur by 38th week. I leave the literature for you. So when is chorionic villus sampling done at 11 weeks? And fundus at umbilicus by 24th week. Anti-D prophylaxis is given to Rh negative women by 28th week. It's called ROGAM, RHOGAM. ROGAM, Rh negative anti-D immunoglobulin is being given at 28th week. Finish. Now comes the next rapid revision table. These are repeated points. Try to do. We do at 18th to 20th week of antenatal visit, anomaly scan. Right?
Yeah.
Then we do amniocentesis at 16 plus or minus 2 weeks, second trimester. Early amniocentesis and epidentro 11 to 13 weeks, but there is a risk of miscarriage. So what are the complications of amniocentesis? Clubfoot, fetal. Why clubfoot? Clubfoot is congenital talipes equinovarus. Why? Because of amniocentesis. If you do amniocentesis, the space becomes smaller,
Yeah.
and due to the crowding, it will clubfoot can occur. So I leave the literature for you. So if you do chorionic villus sampling before 10 weeks, it can lead to limb defects if done too early. Then amniocentesis low, there's a risk of culture failure. There's a reason repeat amniocentesis need to be done whenever you do amniocentesis to do the karyotyping. Then cystic fibrosis wants prenatal diagnosis of their fetus. Chorionic villus sampling is done at 11 weeks, 11 to 13. Then chordocentesis means fetal blood sampling. It is used for identifying RH isoimmunization, etc., etc. If you do transvaginal ultrasound, gestational sac is seen by 4 to 4.5 weeks, 30 days from LMP or 15 days post fertilization. Right? Fetal pole is detected by 5 weeks. Cardiac activity 5 to 6 weeks. Nuchal thickness. Where will you see increased nuchal thickness? Down syndrome, Edwards, Patau, and Turner. Double decidual sign is decidua paritalis and decidua basalis. It is seen by 5th week and it confirms that there is an intrauterine pregnancy. So what is pseudo-sac sign? Instead of 2 rings, there is only single ring, which is sign of ectopic pregnancy. Right? Then what will be the crown rump length by 6th week? 5 mm. And ఇవన్నీ గుర్తుపెట్టుకోవాలండి. So what sign confirms intrauterine pregnancy? Double decidual sac sign. Then single ring like sac, not double, ante ectopic pregnancy. Similarly, a fetus suspected Duchenne's muscular dystrophy undergoes diagnostic testing, which confirms ante muscle biopsy of the fetus. And especially if the first child already DMD అనుకోండి, then next child we have to do all these things. So I leave this literature. When we'll use biparietal diameter for timing the gestation, 14 to 20 weeks. Right? Similarly, crown rump length timing, ideal time to measure CRL is at 7 to 10 weeks. Femur length is used in 3rd trimester, BPD is used in 2nd trimester, crown rump length in 1st trimester. Right?
Yeah.
Then abdominal circumference is an indicator to detect the intrauterine growth retardation. Then nuchal translucency. Commonest cause is increased translucency cause ఏంటి? Down syndrome. Right? ఇవి కొంచెం టపాట చదవండి. But these questions, ఏది nuchal translucency measured 4.5 ante trisomy 21. Similarly, 8 weeks pregnancy means crown rump length.
Yeah.
Then IUGR suspected ante, what is the next step? If the abdominal circumference is less than 10th percentile, it is IUGR. So you need to do 2 to 4 weekly ultrasound monitoring. Thank you. Pardon. సో ఇదన్నీ నెక్స్ట్ ర్యాపిడ్ రివిజన్ టేబుల్, ఇవన్నీ మోస్ట్ ఆఫ్ థింగ్స్ ఆర్ రిపీటెడ్ డాక్టర్. ఇక్కడ ఇంపార్టెంట్ లెమన్ సైన్, బనానా సైన్ గుర్తుందా లాస్ట్ టైం. Typically, when there is a spina bifida, there will be indentation of the fetal frontal area.
Okay.
That is called lemon sign. Similarly, cerebellum become prolonged like a banana pulled down in Arnold cherry malformation. ఈ రెండు ఒక్కసారి మీరు దీంట్లో చూడండి. In Google,
Yeah.
you try to review these two.
Yeah.
Okay. Now, doctor, 13-week-old fetus, absence of skull vault is a feature of anencephaly, lemon sign, banana sign in neural tube defects, Arnold cherry malformation. So a second trimester showing splaying of the vertebral arches with a lemon and banana sign. Which condition? Open spina bifida. A pregnant woman's previous NTD. How much folic acid you should give? 4 milligram per day. Now, continuing our journey, doctor. ఎక్కడి దాకా వచ్చినాం మనం?
94.
Wow. 6 more runs. Century. Now, what is the time to do the I quickly leave the literature for you. ఇవన్నీ చదవచ్చు, పెద్ద విషయం ఏం లేదు. Most of these things we finished. 13-week pregnant woman, first trimester, NT scan. The nuchal translucency is 3.8 mm and nasal bone is absent. What is the abnormality? Trisomy 21. A fetus show choroid plexus cyst on 18-week scan, but karyotype normal. Karyotype normal. Choroid plexus cyst is most commonly associated with trisomy 18. Then a first trimester screening of Down syndrome. What is the best combination? Increased beta HCG, decreased PAP, and increased
Nuchal.
thickness, nuchal thickness. Next, doctor. Where is the uterus? By 20th week, uterine size at 20 weeks is 20 centimeters.
Okay.
28th week,
28.
28 centimeters. But the fundal height calculation is unreliable after 28 weeks. Then when will femoral epiphysis will appear? 36th week.
Right.
Tibial epiphysis, proximal tibial epiphysis will appear by 40 weeks. If the distal femoral epiphysis is not seen, that indicates prematurity. Presence of the proximal tibial epiphysis indicate maturity. Okay. Then bubble test. It is a bedside test to know the fetal lung maturity in the amniotic fluid. In the amniotic fluid, you will also calculate the lecithin sphingomyelin ratio. LS ratio more than 2 unte, lungs are mature and surfactant is produced. LS less than 1.5 unte, there is a neonatal respiratory distress syndrome. Okay. Then, I leave the literature for you. Now, 36 weeks fetus, absence of distal femoral epiphysis, what does it indicate?
Premature.
Very good. In diabetic pregnant women, which confirms lung maturity?
Diabetic.
Phosphatidyl glycerol levels in the amniotic fluid is the best way. LS ratio is an indicator. Best ante phosphatidyl glycerol levels in the amniotic fluid is the best way in diabetic mother. LS ratio is 1:2. What is the likely implication? There is a risk for neonatal respiratory distress syndrome. Then lamellar body count. Lamellar body count. It is an indicator of fetal lung maturity. It is very rapid and sensitive. And if the lamellar body count is done after 32 weeks, delivery is safe. If there is any premature rupture of membrane. And phosphatidyl glycerol is the sensitive test of lung maturity, but not useful if less than 35 weeks. Right? Then in other people you can do LS ratio, but not in diabetics. That's the reason what is best in diabetics? Phosphatidyl glycerol levels. Glycerol levels. Right? Then, what is Spalding sign? Whenever intrauterine fetal death is there, there is an overlapping of the fetal skull bones, which is called Spalding. What is Robert? Gas shadow in the heart and blood vessels because of the IUFD, intrauterine fetal death. When will Robert sign appear? 12 hours to 2 days after the fetal death. Right? Then I'll leave the literature for you. Now, premature rupture of membrane undergoes fetal lung maturity assessment. What's the best way? Lamellar body count. 34-week pregnant woman undergoes the fetal lung maturity testing. What is the best way? Phosphatidyl glycerol present in the amniotic because she is a diabetic woman.
Yeah.
A 38-week fetus show overlapping skull bones. What is your diagnosis? Intrauterine fetal death is what we need to remember. Right, doc? Wow. 102 pages. ఎక్కడ ఎన్ని గంటలు పట్టింది?
2 hours 20 minutes.
ఒక 20 నిమిషాలు బ్రేక్ తీసేసిన కూడా 20 నిమిషాలు ब्रेक निकाले तो भी हम 2 घंटे में 100 पेजेस खत्म किया. सो दैट मीन्स पूरा कितने पेजेस है? 250 है. 50 per hour is the run rate per
5 hours.
ఒక టేబుల్ ఒక నిమిషం లేస్తుంది.
Yeah.
సో యా Now, how is the amniotic fluid formed? Less than 12 weeks, it is from the maternal plasma as ultrafiltrate, and 12 to 20 weeks, it is the transport via skin. The horny layer is absent before 20 weeks. So 12 to 20 weeks, transport via the skin of the fetus. More than 20 weeks onwards, fetal urine is the one which is responsible. So typically the fetus swallows the amniotic fluid between 8 to 11 weeks. Now, the amniotic fluid, maximum amount of volume, when does it form? 28 to 36th week, 1200 ml at 32nd week. So all these different times, different values, jara yaad rakhna. When do you call oligohydramnios, doctor? If the amniotic fluid volume is less than 200 ml, right? And now, 33-week pregnant woman has an amniotic fluid index of 1100 ml, which is the true? Yes, normal for that age. Amniotic fluid at 30 weeks is primarily produced by fetal urine. 41-week fetus show a amniotic fluid volume of 180. What is the interpretation? Oligohydramnios. Then we have the amniotic fluid index, normal height of the vertical pockets. You do assessment through ultrasound. A5, normal range 5 to 25 centimeters. Less than 5 is oligo, more than 24 is poly, right? Then ఇందులో కొన్ని అన్ని గుర్తుపెట్టుకోగలే కొన్ని అట్లీస్ట్ వాట్ ఈస్ హై వాట్ ఈస్ లో అండ్ ఏఎఫ్ amniotic fluid more than 2000 ml is seen in polyhydramnios. So what leads to polyhydramnios causes etiology? Maternal diabetes, fetal anomalies, and anencephaly. Why anencephaly? Whenever the anencephaly is there, the antidiuretic hormone becomes excessively produced. Right? No. Antidiuretic hormone is not produced.
Yeah.
If ADH is not there, there is no antidiuresis. That means there is a diuresis. That means there is more fetal urine. That means there is a polyhydramnios is what we need to remember. Good today, causes. Then 36 weeks, pregnant woman has fluid index of 4.5. That is oligo. Deep vertical pocket of 9.2 centimeters, anything DVP, deep vertical point, more than 8 centimeters is polyhydramnios. 34-week has AFI of 14.5. What does that indicate? Normal. Right? Then, common cause of oligo renal agenesis. It's called Potter's syndrome. Common cause of poly is esophageal atresia and neural tube defects. Esophageal atresia, why that lead to poly? Normally, amniotic fluid is being swallowed. If it is not swallowed due to the esophageal atresia, that get collected. So what is the polyhydramnios anomalies? Anencephaly, microcephaly, encephalocele. What are the maternal causes in the mother leading to poly? Diabetes, RH isoimmunization, and rubella and syphilis. If there is an oligo, what can happen? There is not much space available to deliver normally. So breech presentation, IUGR is more common. And if there is any poly that stretched out uterus quickly goes into labor. So poly leads to preterm labor is what we need to remember. There is no specific treatment for oligo. Right? Then poly, you can do amniocentesis up to 2 liters nikal sakte at 500 ml per hour. Then what is meconium stained amniotic fluid? Whenever there is any fetal distress, breach, transverse lie, or listeria monocytogenes infection, that lead to the development of meconium stained fluid. Golden colored amniotic fluid is a feature of RH incompatibility. Greenish yellow amniotic fluid is post maturity. Dark yellow tobacco color is intrauterine fetal death. Dark blood stained is abruptio placentae. Innune. Daridram. But we have to remember. Okay. Now, doctor, 36 weeks pregnant woman, AFI of 26 centimeters, single deepest pocket is 9.2, more than 8. Poly. Bilateral renal agenesis Potter syndrome is oligo. Greenish yellow amniotic fluid is post maturity. Bhajan karo, NEET PG, bhajan karo. If somebody said I'm brilliant and got seat, bullshit. जो फेविकॉल लगा के उसके ऊपर बैठ जाता without getting away from reading room, he is the winner. No secret. Now, doctor, what is the fetal part of the placenta? Chorion frondosum. Maternal part is decidua basalis. What is the type of the placenta humans have? Discoidal, hemocorial, deciduate, chorioallantoic. Hemocorial, discoidal in shape, decidua will be there, parietalis, basalis and all. Chorioallantoic, chorion frondosum and all fetal component will be there. This mana placenta description. Fetus to placenta weight into the 6:1 at term. Right? Yeah, number of cotyledons 15 to 20. Each has 3 to 5 lobules. Placenta weight 500 grams. Placenta में क्या barrier layer? Syncytial trophoblast, cytotrophoblast and basement membrane. Now, what are the main hormones produced by placenta? HCG, HPL, HCT, HCC, even. Now, what are the 2 steroids produced by the placenta? Estrogen and progesterone. What are the 4 hormones that do not cross placenta? Remember, insulin does not cross. Mother-la hyperinsulinemia unna kuda doesn't cross. Mother ki insulin ichina kuda doesn't cross. Insulin, TSH, calcitonin, PTH, they do not cross placenta. Circumvallate placenta. It has got a central depression due to double folding of chorion plus amnion. Circummarginate placenta, no central depression. Circumvallate placenta, what is the risk, doctor? PPH, preterm labor, subinvolution. What is subinvolution? After puerperium, you are expecting involution. The circumvallate papilla, కొన్ని products of conception remain in the uterus, leading to subinvolution. Right? So, succenturiate placenta, it has an accessory lobe separated by membranes. Okay? So, what is the functional unit of placenta? Cotyledon. Cotyledon के अंदर क्या रहता? Lobule. Any cotyledons ఉంటాయి? Any? How many are the lobules? 3 to 5. Okay? Now, doctor, a term placenta shows central depression, circumvallate. Eggir Gantesh answer cheyali. 500 grams, which is most accurate about its fetal weight. Placenta to fetal weight ratio ఎంత ఉంటుంది? 1:6. అది ఫండ. ఇది 500 అయితే అది 3 kgs ఉంటాడు వాడు. Which hormone do not cross placenta? Amma, insulin. ఇది వస్తుంది రేపు ఎగ్జామ్ లో. Then vasa previa. Battledore placenta అని చదివినాం కదా other day. The umbilical cord will insert into the edge of the placenta. So their fetal blood vessels can exsanguinate and can lead to the development of the bleeding. Vasa previa. Okay. Then velamentous insertion. The cord will insert into the membranes instead of into placental disc. Danto, fetal vessels are prone to leash over the internal os and lead to bleedia. Vasa previa can occur even with the velamentous insertion. Then, whenever monoamniotic, monochorionic twins are there, they are at the high risk of cord entanglement because these twins share amnion and chorion. Umbilical cord వచ్చి ప్లాసెంటాకి అటాచ్ అవుతాయి కదా, సింగిల్ amnion సింగిల్ chorion ఉంటే కనుక there is a greater risk of cord entanglement in monoamniotic monochorionic twins. Now I'll leave the literature for you to quickly review. Different types of marginal insertion of the cord is called as battledore placenta. Okay. Now, the placenta delivered has a accessory lobe, increasing risk of PPH. What is that called? Succensuriate lobe. Fetal blood vessels are ruptured. There is a bradycardia, vasa previa. Placenta previa laga vasa previa. But placenta previa lo, the source of bleeding is maternal blood vessels. Vasa previa mein fetal blood vessels. Then umbilical cord is inserting into the membranes with vessels traversing a long distance in placenta. It is velamentous insertion. Okay. Then placenta కొంచెం long lengthy అయిపోయింది కదా. कितना है number? 115. Okay, 2-minute break and placenta is killing me. Okay, let's just finish placenta and take break. Battledore placenta, cord comes, attaches to placental margin. Vasa previa risk is there. Placenta accreta means they will typically penetrate into the myometrium and there is an absence of Nitterbuch's layer. Placenta increta means will I invade into myometrium only. Percreta means myometrium serosa even go to bladder. Accreta risk enti placenta previa, it can lead to uterine scar, etc. So previous cesarean section, why placenta accreta will occur, why the placenta will go and so deeply implant previous lower section చేశారనుకోండి myometrium ki, that point of injury will be a source for it to penetrate. It's like a Jumanji movie. చూశారా Jumanji? Like spreading of the roots. Accreta ఉంటే ఏం చేయాలి? If she is already a Paris woman, do hysterectomy. Young woman, conservative.
Yeah.
Now, where do you see large placenta, small placenta? Polyhydramnios, CMV infection. What is the torch group of infections? Toxoplasma, rubella, cytomegalovirus, and herpes. They are all called torch. అందులో cytomegalovirus infection unte placenta will be large. It lead to RH incompatibility. I mean, RH incompatibility also can cause large placenta, diabetes, twins, nephrosis. Small placenta in IUGR or 42 weeks kelpin pregnancy, placenta becomes small. Now, doctor. Ultrasound shows anterior low-lying placenta with lacunae, turbulent blood flow. What is the diagnosis? Placenta accreta. How do you identify it? Placenta accreta, ultrasound chudandi. How it will be invading into the myometrium and highly vascular. Okay? So previous LSCS plus placenta previa plus Doppler lacunae is equal to placenta accreta. Now, a woman delivered vaginally, but the placenta does not separate even after 30 minutes. What is the pathology? Increta. no placental separation, PPH, uterine inversion. Even uterine inversion కూడా అవుతుంది. దాన్ని బయటికి గుంజుదాం అనుకున్నారు అనుకోండి, the deeply routed placenta which went all the way to maternal bladder, then మొత్తం యూట్రస్ బయటికి వచ్చేస్తుంది. 28-year-old priming gravida has an ultrasound that reveals a placenta with a central hypoechoic defect. That is fenestrated placenta. Central defect in placenta. Okay. Okay. అంతా అదే కథ. We'll take a 2-minute voice break. So welcome back, doctor. Vasa previa. It has a blood of the fetal origin. So how do you identify fetal blood? We use a test called Singer's test. What test?
Single.
Correct. Now, in normal pregnancy, we see vascular villi, capsularis, decidua capsularis, decidua vira. Whereas in ectopic pregnancy, we see only the decidua, no chorionic villi. That is a differentiator. What do you mean by blighted ovum? There is no embryonic development at all, only there are avascular villi, which is, it's like a miscarriage, blighted ovum. Where do we see single umbilical artery, less than 1% pregnancies, but it is associated with anomalies. Huh? Now, normal cord has two arteries, one vein. Then short cord is less than 30 centimeters. Long means more than 100. More than 100 will predispose to cord prolapse. Less than 30 will lead to malpositions and abruptio, sudden separation of the placenta leading to retroplacental bleed. Cord attaching to the placental margin is called battledore placenta. Huh? What is meant by Hopkins fold? So basically, umbilical arteries, when they approach the placenta, they cross a transverse fold in the intima called Hopkins fold, the squeeze. Singer's test is positive means typically it is vasa previa. A neonate is born with a single umbilical artery. It can lead to associated fetal anomalies. Margin of the placenta, cord got inserted, battledore placenta. Now, let's take some important tests to know the fetal well-being. Contraction stress test and oxytocin challenge test. They used to give IV oxytocin and look for the uterine contractions. It is no more done. Right? No longer used in current obstetric practice. Now, what is done is non-stress test. There is a way to know the fetal well-being. There is a scoring system called Manning score, by which you calculate the biophysical profile, BPP. So what is the non-stress test? You don't give any oxytocin to cause contractions. Whenever the fetus is undergoing the movements, the fetal movements are supposed to lead to the fetal heart rate acceleration, and you follow that. That's called non-stress test. The most common test for fetal well-being. What is a reactive non-stress test criteria? More than 2 accelerations of more than 15 beats per minute, lasting more than 15 seconds in a 20-minute observation interval is called reactive non-stress test. Okay? It is called reactive. If it is reactive, normal fetal health. Right? So what does non-stress test is monitoring? Fetal heart rate pattern with the movement of the fetus. Who will tell my fetus is moving? The mother. One balloon will be there every time the fetus moves. then the fetal heart rate is monitored. So what is cardiotocography? With uterine contractions, how is the fetal heart rate pattern? Normal fetal heart rate is what? 110 to 160 beats per minute. Normal variability is around 6 to 25 beats per minute. When do you call acceleration? If there is an increase in fetal heart rate more than 15 beats per minute for more than 15 seconds, at least 2 in 10 minutes. Right? So, normal CTG, cardiotocography में there will be no decelerations. So if there are decelerations, they can be early, late, or variable. Variable is cord compression. Early is head compression. Late is uteroplacental insufficiency. Variable is cord compression.
Cord compression. Early is fetal.
Head.
Head.
Head la HEAD kada.
Yeah.
Early is head eskondi. Tarata variable is
Cord.
compression. VC is vice chancellor. Some stupid way to remember. A మిగిలింది late is uteroplacental insufficiency, which will make the fetus die and late.
Yeah.
గుర్తుంటుందా? చెప్పండి. Early decelerations are
Head.
head compression. Variable are
Variable is cord compression.
and late decelerations are
Utero.
fetal placental, uteroplacental insufficiency. So I leave the questions for you to answer. ఇట్లనే ఉంటాయి questions. Then whenever there is less than 5 beats per minute variability, no accelerations, late decelerations for more than 40 minutes, it is ominous sign. Right? Then variable decelerations. Variable decelerations are typically seen with cord compression. Now, what is meant by sinusoidal pattern? It is like the ocean. It keep on rocking without too much of waves. So whenever there's a fixed baseline fetal heart rate without variability or acceleration, that is called sinusoidal pattern. Right? So what is the cause of sinusoidal pattern? Any vasa previa, narcotics used by the mother, not the baby yet. Inga feed appude ekkada modelu peduthe narcotics. Fetal anemia and RH isoimmunization. They all lead to sinusoidal. Early deceleration is head compression. Early deceleration, how can you prevent? You can give atropine. Variable deceleration, cord compression. Late deceleration is uteroplacental insufficiency. Late is always ominous. Okay? Now, doctor, this is what? Head compression is a feature of early deceleration. Cord compression is variable deceleration. UPI is late deceleration. Right? Mommy. So, ఇదంతా కూడా మళ్ళీ అదే స్టోరీ. Try to go. What is biophysical profile? The gross movement of the fetus, the fetal breathing, the tone, amniotic fluid index, and non-stress test. And with the heart accelerations with the fetal movements.
Yeah.
These are the components, 5 components of BPP. Mala చెప్పండి. Gross fetal movements, the fetal breathing, the tone of the fetus index and NST. Gross fetal tan. అట్లా గుర్తుపెట్టుకోండి. Score is out of 10, each parameter has 0 or 2. So 30 minutes you need to observe for this BPP, biophysical profile. Right? Now you are ready with that. Baseline 105, variability less than 5, poorly defined accelerations. What is the category? It is non-reassuring. Fetal heart rate 95, variability less than 5, late deceleration more than 3. That is also abnormal CTG. A BPP is being performed. 2 limb movements, 1 fetal breathing movement, normal tone, single vertical fluid more than 2, and a reactive NSC. What is the score? All are maxima. So 2 into 5, 10. 10 by 10 BPP. Score 2 if more than 2 accelerations, more than 15 beats per minute, lasting more than 15 seconds in 20 to 40 minutes. Only 0 to 1 acceleration in 20 to 40 minutes is score 0. Atla, all these scores, everything try to catch up. Modified BPP means they included uses only 2 things, NST and AFI. Because they are all objective measures. Mithani subjective kada. Fetal movements, tone, avanni. So modified BPP uses only NST and AFI. Right? So then the very important thing called middle cerebral artery color Doppler of the fetus. In that, we calculate the systolic to diastolic ratio, Doppler wave. And also, we calculate if this ratio is in MCA, middle cerebral artery, is less than in the ratio calculated in the umbilical artery, then that is considered to be abnormal. The MCA Doppler. So what are the various vessels? Their Doppler pattern is indicative of how good is the uteroplacental sufficiency. Uterine artery, umbilical artery, MCA, and ductus venosus. Right? ఇది కొంచెం చూడాలి మీరు. You have to go through the Google to look at how these patterns of the MCA Doppler. No breakfast. No breakfast.
Sure.
No. You are getting delayed by breakfast. Is it okay?
Huh?
I don't take breakfast.
Oh,
You
okay. Yeah.
మీరు పర్లేదా? మేనేజ్ చేస్తారా?
Yeah.
ఇప్పుడు ఎక్కడున్నాం మనం?
1:30.
IPL స్కోర్ లానే ఉంది. 200 కొడితే మ్యాచ్ గెలిచినట్టు.
Yeah.
మీరు 250 పేజెస్ ఒక ప్రింట్అవుట్ తీసి పెట్టుకోండి.
Okay.
పెట్టుకున్న తర్వాత రివ్యూ చేయండి.
Yeah.
Okay. Actually, obstetrics gynecology is very big.
Yeah.
So once more question will come. A fetus has BPP more than 3 limb movements, 1 fetal breathing more than 30 seconds, normal tone, AF pocket more than 2 centimeters, but NST shows no accelerations. What is the score? All of them are 2 except NST is equal to 0. So total 8 instead of 10.
Okay.
Modified BPP showing absent accelerations and AFI is equal to 3. What is the next step? AFI, non-stress test plus AFI less than 5 is abnormal. Modified BPHP score less than 5 is abnormal. Deliver the baby if it is mature. 34 weeks and mature.
Over 32.
Or 32 weeks. Come on, get out and intro. MCA Doppler shows S by D ratio less than umbilical artery and a low PI. That is an indicator of fetal anemia and fetal hypoxia. So, Atlanet. Next. What is meant by ఒకసారి పిఐ అంటే ఏంటి చూడండి ప్రెజర్ ఇండెక్స్ వాట్ పిఐ ఎంసీఏ పిఐ ఫుల్ ఫామ్ సెరిబ్రో perfusion index, pulsatility index, correct. So the pulsatility index in middle cerebral artery divided by umbilical artery PI is an indication of how the cerebroplacental blood flow occurs. So that ratio is important. Normal MCI में flow कैसे रहता? High resistance flow, right? बट अगर फीटल हाइपोक्सिया हो गया तो एमसीए में लो रेसिस्टेंट हो जाता. Because of that, the pulsatility index will become diminished. That's the funda. So any CPR less than 1, where the umbilical artery pulsatility index is more than the pulsatility index of MCA, it indicates fetoplacental insufficiency. Right? Now, the waveform of the blood in the ductus venosus. Where is ductus venosus? The liver, and connects the umbilical artery with the IVC. So, the waveforms of the ductus venosus are interpreted to detect the aneuploidies in the first trimester and for the intrauterine growth retardation screening in the second trimester. So there are 3 waves: S wave, D wave, A wave. S wave is highest peak due to fetal systolic contraction. A wave is lowest dip due to fetal atrial contraction. Abnormal A wave means it is a reversed A wave, or absent A wave is always abnormal. And absent A wave is an indicator of severe IUGR, cardiac dysfunction, aneuploidy. Reversed A wave is indicator of fetal compromise. Blood supply come ho gaya. Right? So they will give all the figures: A wave, S wave, ఇంకోటి ఏంటి D wave. ఇది జర ఒక్కసారి గూగుల్ में देखना. So what is the importance of S wave? It is a ventricular systolic function is reflected by the S wave. D wave reflects the ventricular relaxation, diastolic wave. A wave is atrial contraction. But between A wave, D wave, S wave, which is most sensitive, doctor? A. Ventricular systole, diastolic, and atrial systole is a very important marker. Okay. Now a 12-week-old fetus shows increased NT. NT ante nuchal thickness. Absent A wave on ductus venosus Doppler. What does it suggest? Trisomy. Aneuploid. A growth restricted fetus has Doppler showing reversal of the A wave. What do you want to do? That means it is severe compromise. Immediate delivery. 34-week has cerebroplacental ratio of 0.85. It indicates anything less than 1. That is pulsatility index of the MCA less than the pulsatility index of the uterine artery indicates placental insufficiency. Right, doctor? Now, umbilical artery, whenever you do the Doppler, what do you calculate? S by D ratio. S by D ratio more than 3 after 30th week is indicative of IUGR. మనం దాంట్లో కూడా చూస్తాం కదా ఎస్ బై డి, ఎస్ డిను ఏ వేవ్ దేంట్లో డక్టస్ వినోసిస్లో,
Yeah.
అట్లనే దేంట్లో ఇంకా దేంట్లో చూస్తాం అంబ్లైకల్ ఆర్టరీలో కూడా. So systolic to diastolic wave ratio more than 3 after 30 weeks suggests IUGR. Any decreased diastolic flow indicate high resistance in the placental blood vessels. Similarly, absent end diastolic flow indicates IUGR, thrombocytopenia and necrotizing enterocolitis.
Okay.
Right? So, less than 16 weeks gestation low, absent end diastolic flow is okay. So, if the absent end diastolic flow is there in a third trimester baby, then it is an indication for induction of labor. Then there is something called reversal of the end diastolic flow. Ekdam absent kaadu. ఆ రెసిస్టెన్స్ ఎంత ఉన్నదంటే బ్లడ్ ఫ్లో రివర్సలే ఉంది. దట్ ఈజ్ ఇండికేటివ్ ఆఫ్ సివియర్ ప్రీ ఎక్లాంసియా అండ్ ప్రెగ్నెన్సీ ఇండ్యూస్ హైపర్టెన్షన్. राइट? So normal ultrasound, I mean umbilical artery Doppler क्या दिखाएगा आपको? It will show a forward end diastolic flow, and that end diastolic flow can become absent, it can become reversed. Reversed అయితే ఏంటి interpretation? Absent అయితే ఏంటి interpretation?
Reverse pre-eclampsia.
ये सब जरा पढ़ लेना. ठीक है बच्चों? 34th week IUGR, absent end diastolic flow. What is the next best step? Induction or delivery. Reversed end diastolic flow means PIH, terminal pregnancy. Absent end diastolic flow in umbilical artery in 14 weeks. Normal finding up to 16th week.
Yeah.
One 150 వరకు కొట్టి ఆపుదాం. నెక్స్ట్ 100 మీరు కొడతారా?
Yeah.
ఏమంటారు? ప్రామిస్ చేయాలి
Yeah.
పక్కా.
Yeah.
మిగతా 100లో మళ్ళీ నేను క్విజ్ పెడతా.
Okay.
ఐ విల్ ఆస్క్ యూ ఫినిష్ 100 pages.
Yeah.
100 pages మన అకౌంట్లో ఎంతసేపట్లో కావాలి?
2 hours.
2 hours.
Yeah.
కానీ ఇండి సోలో అయితే 3 గంటలు టైం ఇస్తా. 3 గంటల తర్వాత ఫిర్ ఐ విల్ ఆస్క్ సమ్ క్వశ్చన్స్ దట్ మేక్స్ మీ సాటిస్ఫైడ్.
Okay.
We are done.
Yeah.
Okay? అన్ని సబ్జెక్టులు ఉండవులేండి 250.
Okay.
If you take subjects like biochemistry and all,
Yeah.
we conclude it with 150 pages.
Right. Yeah, for puja
Huh?
ఒక పూజ ఉన్నది టెంపుల్ కి వెళ్ళాలంట 11 to 3 hours పడుతుంది. 11 to 2 అయితే దాని తర్వాత
No permission granted.
ఐ మీన్ పూజ అంటే వెళ్ళాల్సి టెంపుల్ కి.
పరీక్ష చదవాలి కదా.
అవును కదా.
ఇదే పూజ.
దాని తర్వాత
మనం చేస్తే పొద్దున పూజ చేస్తున్నాం మనం. 10 to 2.
2 to 5 I'll complete this. Then evening I'll take mock test.
Mock test.
Yeah.
And ఈ 2 to 5 ఇది ఎప్పుడు మన డిస్కషన్, మన క్వశ్చన్
Yeah, whenever.
నైట్
Okay.
అరౌండ్ 9 o'clock.
Okay.
I'll ask questions in the last
Yeah.
100 pages.
Okay.
So that completes
Yeah.
work.
Yeah.
మొదలు పెడితే ఎప్పుడు ఆపకూడదు.
Yeah.
We have to 20 days. We have to pray God and move forward.
Yeah.
Good. At least you are going to temple. You didn't say I'm going to pub. Now, uterine artery Doppler. ఇందులో ఒక ఎర్లీ డయాస్టాలిక్ నాచ్ ఉంటుంది, which is a normal finding up to 26 weeks. Then there is one late diastolic notch. If that is there beyond 26th week, it is indicative of IUGR, vasospasm, small for gestational age. And for every gestational age, you expect certain weight. Small for GA baby unte, late diastolic notch beyond 26th week. Any persistence of the diastolic notch after 26th week is abnormal, which is seen in hypertension and IUGR. Any high resistance in uterine artery. Where do you see? Uterine artery la high resistance index center. Placental abruption, preeclampsia and IUGR. Right? Then when will you do uterine artery Doppler to assess the fetal well-being? Typically 20 to 24th week. Any notch absent after 26 weeks, good, reassuring finding. Any presence of the notch beyond 26 weeks, if it is a late diastolic notch, pathological. Similarly, any reversed diastolic flow indicate a very high placental blood flow resistance, which is seen in preeclampsia. So, ivanni reversed end diastolic flow, abnormal pattern, ivanni kuda you have to go through the Google. Definitely question aayega. Today mock test you should answer 15 by 15 in obstetrics. Let me see. Itna pad rahe na?
Yeah.
Then okay. 28-week pregnant woman undergoes uterine artery Doppler, shows persistent early diastolic notch. What does it indicate? Beyond 26th week is abnormal. So, vasospasm and IUGR risk. Manning score may what is not included? Uterine artery Doppler and BPP. I mean, uterine artery Doppler is not part. Amniotic fluid index, fetal breathing, fetal tone, NST. A previous pregnancy was post-mature. In current pregnancy, how do you categorize? It is not a high risk. And idivarku post-mature ayindi kada, ippudu malla post-mature kaadu. Now comes normal labor. Interesting part. First stage, 12 to 14 hours in primary gravida. 6 to 8 hours in multipara. Cervical dilatation. Every hour 1 to 1.2 centimeters up to how many centimeters? 10. And 1.5 centimeters is a progress in multigravida. Descent of the head. 1 centimeter per hour in primary. 2 centimeter per hour in multi. Now, what is the sequence of labor? Engagement, descent, flexion, internal rotation, crowning, extension, restitution. That's how the baby comes out. How does he come? First engage, biparietal diameter into the pelvis. Then descent. Then flexion. Mummy, I am submitting to your authority. Chin moves to chest and smallest diameter presence. Then undergo internal rotation. Occiput rotates anteriorly. Then crowning. Fetal head is seen at vulva without any retraction. Then extension. Delivery of the head occurs by extension. So, I am coming into this world. Then restitution. The head will rotate to align with the shoulders. And then external rotation. Shoulders rotate and head follows. And expulsion. ఈ సీక్వెన్స్ గుర్తుపెట్టుకోవాలి. దీన్ని ఏమంటారు? ఎడిఫిక్టరీ, ఎంగేజ్మెంట్, డిసెంట్, ఫ్లెక్షన్, ఇంటెల్ రొటేషన్,
Crown.
క్రౌనింగ్,
T.
ఇంకోటి క్రౌనింగ్ తర్వాత ఎక్స్టెన్షనే కదా.
Or delivery of
ఎక్స్టెన్షన్, రెస్టిట్యూషన్.
delivery of head instead of
Mm.
extension.
గుర్తుపెట్టుకోండి. Then what are Braxton Hicks contractions? They're seen in pregnancy, even fibroids, hematometra, into the parametrium if there is any blood seeping. That lead to Braxton Hicks. What is called golden hour? Fourth stage. Third stage placenta వచ్చేసిన తర్వాత
Postpartum.
immediate postpartum period with thermoregulatory chills is called the golden period. So just go through this. Now, partogram, very important. Bishop score, engagement, everything. So what is partogram? You are graphically charting the progress of the labor with time. How many parts are there in partogram? Part 1 has patient and fetal. Second has cervix with the comments. Third is on dilatation and descent with the comments. You will be mapping. So part 1 is fetal condition. It includes fetal heart rate. How is the liquor? Is there any molding? Part 2, labor progress. It tracks the cervical dilatation and fetal descent. Part 3 is the maternal condition. It records the pulse, BP, temperature, urine and contractions. So that is the gold standard to monitor the labor. Right? So what are the components of Bishop score? What is the purpose of Bishop score? How ready is the uterus for the NEET PG entrance? So the pre-labor cervix readiness for induction is assessed by the Bishop score. So it contains the dilatation, effacement, consistency, position and station. Favorable score is more than 6/13. Total score is 13. That means labor is likely to start and anything less than 4 needs cervical ripening. You need to ripen the cervix. So, what is synclitic engagement of the fetal head? If the sagittal suture is in the midline of the pelvis, you call it as synclitic engagement. Asynclitic means the parietal bone is tilted. Parietal bone is tilted. You call it as asynclitic. Asynclitic posterior means it is towards the pubic symphysis if it is tilted, fetal skull. Right? So common way by which the fetal skull will have an engagement in nullipara is not with synclitic engagement. And a sagittal suture midline lo pettukoni raadu vaadu. The baby will come with posterior asynclitism, especially in nulliparous women. Right? Now, I leave quickly solve these questions. Now, fetal diameters, pelvic types. Right? Good to see 5 online classmates. Please punch the voice loud and clear, doctor. Thanks for joining. कितना चल रहे हैं? 8, huh?
146.
6, huh?
Yeah.
Oh, good, no? Arey, what a stamina. Excellent. Totally 250 pages are there in this notes. We finished 145. कितने घंटा लगा बेटे?
3.5.
3.5, huh? Half an hour breaks. 3 घंटे में 150. अच्छा चल रहा है. Huh? 50 pages per hour is the run rate. Good, man. అంటే 1 minute, 1 page is as good as 6 per hour.
Yeah.
Most common presentation of the labor vertex. Most common lie, longitudinal line. Engaging diameter in vertex, suboccipital-bregmatic, which is 9.5 centimeters, where the fetus is in complete flexion. Right? Then, what is the largest fetal AP diameter? Mento-vertical, which is 13.9 centimeters if there is a bro presentation. What are the most common cause for the non-engagement in primate? If there is any deflexed head, whose diameter is more than the pelvic diameter that it is negotiating, that's called cephalopelvic disproportion. Face complete engaging diameter in the face presentation is submento-bregmatic, which is 9.5 centimeters. If the face is in incomplete extension, it is submento-vertical diameter is most common. Pelvic types. Gynecoid, most common. Android, difficult labor, perineal injury. Anthropoid will lead to very narrow outlet, face to pubis. Persistent occipito posterior लगा के occipit ऐसा ही रहता. The kid want to do swimming with back. Platypelloid is transversely oval inlet, very wide. In this face presentation occur. And any android pelvis will lead to deep transverse arrest with a delayed engagement. Anthropoid will lead to persistent occipito-posterior position due to non-rotation. Platypelloid will lead to face presentation. Hence, gynecoid is the best. Okay? So, try to finish this, doctor. Right? Then, some more. Obstetric diagonal true conjugate. Obstetric conjugate means everything is taken from sacral promontory. You have the pubic symphysis, sacral promontory, you are calculating the diameters. Sacral pubic symphysis has got upper border, lower border, middle border. Right? What is obstetric conjugate? Shortest AP diameter of pelvis from middle 10 centimeter. Diagonal and typically lower border nunchi you calculate 12 centimeter. True conjugate is from upper border of sacral promontory to sacral promontory, 11 centimeters. So obstetric conjugate is from midpoint to the sacral promontory. Okay, గుర్తుపెట్టుకోండి. So largest fetal AP diameter, mento-vertical diameter. What is the transverse diameter of the pelvic inlet? 13 centimeters. Pelvic cavity, 12 centimeters. Obstetric outlet, 10.5. What is obstetric outlet between the two ischial spines? Bispinous diameter is called obstetric outlet. Anatomical outlet is between the two inter-ischial tuberosities. That is 11 centimeters.
Yeah.
So, इवన్నీ जरा एक मर्तबा इस्त्री मारना. Then comes the stages of labor. First stage, cervical dilatation. Second stage, delivery of fetus. Third is placenta. Fourth is postpartum.
Yeah.
I leave the literature for you. And कहते active phase ఎంత, nulliparous ఎంత, multiparous ఎంత, by heart करना बेटा. पास होने के लिए दिमाग का जरूरत नहीं होगा. किसका जरूरत होगा? फेविकॉल का. फेविकॉल लगाओ, बैठ जाओ और पढ़ो. Then comes prolonged labor and latent phase. When do you call precipitant labor? in case of the multiparous woman, entire first to second stage of labor will be less than 2 hours. Ever grand multiparallel. That is precipitate. Even while passing motion also baby can come out. Then prolonged labor, when you call any duration more than 18 to 24 hours or failure of cervical changes. That's the reason, what is the rule? Never the sun should set twice on the laboring woman. 2 సార్లు సూర్యాస్తమం అయిందంటే patient gone. Because maximum 24 hours. So I leave the literature for you to know the definitions. Prolonged active phase, prolonged second stage, primary में क्या है, multi में क्या है, पढ़ना पड़ेगा. अभी मैं बताए तो मजा नहीं है, कैसे भी भूल जाते. आप अपने आप पढ़ना. One MCQ sure short to come. Doctor?
Yeah.
In this. So what is PROM?
Premature rupture.
Of membrane. PPROM. PROM less than 37 weeks is preterm PROM. Right?
Yeah.
And only PROM means before the onset of labor, if there is any rupture of membranes, then that is called premature. What is the definition of protracted descent? What is second stage arrest? What is the active phase arrest? ये सब चीजें. Then how will you do artificial rupture of membranes? In order to hasten the labor, we use Kocher's forceps. The Google image, how it looks like. What is the contraindication for you to do the artificial rupture of membranes? In early deceleration, if you are seeing, don't do ARM. It's a relative contraindication. In polyhydramnios, you do controlled ARM. ARM is done for what? Induction of labor. Right? And what is the contraindication for ARM? Intrauterine death. There, what will you do? You will give oxytocin like medical induction to contract instead of cutting the amniotic membrane. Could you get that? Post-dated pregnancy means if you are doing induction at 41st week, you call post-dated. But that has a risk of meconium aspiration by the baby. So we question solve cheyandi. So with this, we will call it a day, doctor. NNA 157. So the whole secret is believing that we can complete the revision, sticking even though we feel like getting away next 20 days. Yeah? Thank you very much. And see you all every day morning 5 a.m. to 9 a.m. with Dr. Murli Bharadwaj. Thank you.